All right, so tonight we're going to be going over anatomy. Now, I've got some good news, and that is that I don't expect you to be masters of anatomy, especially after tonight. This is not the only time that you're going to visit this chapter, so I don't want you to think that you have to get everything in this on the first attempt. This chapter will really set you up for trauma. You're going to find when we get to the trauma module that almost every night the schedule says review chapter 6, blah blah blah, whatever page number. That's the stuff that's going to be pertaining to that particular module. So we're gonna hit it as an overview tonight. There is over 100 slides, but we're not gonna dwell on a lot of them very fast or for very long rather. And I just want you to come out of tonight with a general understanding. Like I said, we're going to hit each individual portion again as we go through the book. Um, Pay attention to some of things like the endocrine system. A lot of people struggle with that one. Mostly what we worry about with the endocrine system is for diabetes purposes. So that stuff will come back up when we hit the diabetes chapter and some other endocrine issues. All right, so we'll get through these slides because these don't really, you don't have to read those. Whoop. All right, so it's kind of hard to do our jobs as EMTs if we don't know the layout of the body. That's usually really apparent when we're talking about things like trauma, because if you don't understand how the bones work, for example, then when you go to try to put a splint on somebody, it may be completely ineffective, right? We got to know like what bones are responsible for allowing us to flip our palms up and down. If you splint it the wrong way, it doesn't really do anything. Your patient can still continue to damage themselves even with the splint in place. When we're talking about medical calls, knowing your anatomy is what allows you to kind of figure out, well, if you've got these pains, this is probably what's going on. I know that. Let me ask you this, because I haven't, unfortunately, Brad, when he taught the medical terminology class, he wasn't able to record it. I noticed that was a really short class because I saw how fast y'all got your attendance forms in. Did y'all cover the whole chapter or did it get cut short?
I want to say he covered the whole chapter. It just went pretty fast.
Okay. All right. I don't want y'all to. I mean, that chapter right there, first of all, it's boring as hell. I mean, a lot of the chapters in the EMT are, especially when you're talking about it from a lecture standpoint. But I want to make sure y'all understand a lot of the words that you were supposed to know in that chapter because we're going to use them moving forward. Um, so okay, yeah, I heard he wasn't feeling good that night. Um, but like certain words like supra or inferior, that sort of thing, dorsal and ventral, especially in this chapter, we're going to be using some of those words. So if you don't know the word, that's fine, especially at this point. If I ask a question and you want to say just in front of or above, you can. But if you can remember what those words were, especially the words that sent you in a direction, try to get used to using them. If you have an injury that's proximal to a certain location, or something that's medial or lateral, that kind of thing. I want you to get used to saying those terms, because especially when you do your documentation, that's what you're going to use. You may not necessarily talk to people with those words, but when you do anything legal, like let's say patient care report, you're going to want to start using professional terms, that sort of thing. So we do use a couple of areas or a couple of terms that actually direct you around the body, so that if you are just talking to somebody, like I'm talking to y'all, and I say that if I start trying to pinpoint where something is out on the body using the terms that you're going to learn tonight, you can kind of figure out where I'm saying the injury is at, as opposed to me having to point at it and say, it's right here, that sort of thing. There's three main areas depending on how the body is divided. You have your frontal plane, your transverse plane, and your sagittal plane. I believe there's a picture for that. There we go. So this is basically just cutting the body into sections. Your frontal plane cuts your body into front and back. If anybody's ever seen that horror movie, House on Haunted Hill, that is always what comes to mind when I talk about that. Your transverse plane divides the body top and bottom, and it usually the plane can move. These planes can be anywhere, but as you see in the example, this typically happens around the belly button. The sagittal plane cuts your body into left and right, and that's the one we're going to be talking about the most when we start using terms about where something is located on the body, because especially if you go on to be an advanced EMT or a paramedic, you'll learn, where we put a needle for a decompression, for example, could be on the mid-sagittal line, or um, the mid-clavicular line, or something of that sort, and you're referring to where this particular plane is. The mid-sagittal line itself is actually called your midline. So where it says sagittal lateral plane, and where you see that blue, what looks like a piece of glass kind of going right through the middle, that is your midline. And that is going to be the center point and the starting point for almost all of your directional terms. All right, so the first system we're going to talk about tonight is the skeletal system. There are 206 bones. Let me ask you this. Is there a difference in the amount of bones between the female and under normal circumstances?
I think doesn't female have less ribs?
Well, if you think religiously, technically the male would have less ribs. However, scientifically, no. There's the same amount of bones from male to female. There's only 206 bones. The skeleton, it's really hard to tell whether, like, if you're just looking at a bone count, you really can't tell the difference between a male and a female bone. Most of the differences are going to be in the hip range. So when somebody's looking at a skeleton, if you can see the pelvic girdle, you can kind of determine whether it's a guy or a girl. But by the bone count, it's actually the same. I'm not going to make y'all learn all 206 bones. That would be dumb, especially for an EMT lab. If you were going to nursing school, you would need to know all the bones, but not for this level. We're going to talk about the main ones, the ones that we typically see people break. But these constitute the structure of your skeletal system. This is what gives our body the shape, and it is what allows our muscles to move us around, right? So your muscles are going to attach to different bones, and whenever they contract, they pull that bone, and that's what allows you to move. You have your ligaments. Your ligaments connect bone to bone. So, like the setup of your elbow, your knee, those kind of areas, you're going to have a network of of ligaments that connect through them. Your tendons are what connect your muscle to bone. And then you have your cartilage, where if you've got two bones kind of sitting on top of each other, sort of like your spinal column, the cartilage is what allows for the cushioning between those bones. You also see cartilage in things like your ear, your nose. Most of your nose is actually cartilage. It's not a full bone. So even though there is a bone prominence there, most of your nose, that's why it's so flexible. The skeletal system is divided into two portions. You have your axial skeleton and your appendicular. Your axial skeleton, that's your skull, your spinal column, and your thorax, which is your rib cage. So all of the central bones, that network is your axial skeleton. That's what protects your brain, most of your thoracic organs like your lungs, your heart. Your diaphragm isn't necessarily protected by it. Your diaphragm kind of sits at the bottom of your rib cage, but your spinal cord runs through your spinal column, so that's protected by it. And then actually, we'll get to that. So let me stop getting off track here. Your skull, you have your cranium and your face. You don't need to know all these bones. The only one I really want you to know, as far as it's concerned, will be your mandible, because that one gets dislocated a lot when people get hit in the face. So you'll see that happen in certain contact sports. You'll see it happen in car wrecks, that sort of thing. If you get questions regarding that, just recognize that bone. All right, that's one of them. The rest of these bones, your temporal bones, zygomatic, all that stuff, if you've been through a college anatomy course and you've memorized that stuff or had it beaten into you, then great. But you don't necessarily need it for this course. Just know that there's a lot of bones that make up the face, the cranium, that sort of thing. Your spinal column is composed of 33 bones and it's divided into 5 sections. So we have the cervical, which is your neck. That's why we call them C collars whenever we're talking about putting them on patients, the little plastic things that hold your neck steady. Your thoracic, which is your upper chest, your chest, that area, that's your rib cage. Your ribs mostly connect to those. Your lumbar is your lower back, and then you have your sacrum and your coccyx. Now, there's a set amount of bones in each of these regions. Can anybody tell me how many are in your cervical, thoracic, and lumbar regions?
Her name. It says it's 7, 12, 5, 5, 4, right?
Yep. Good job. So 7, 12, and 5, that's your cervical, your thoracic, and your lumbar. That's what we really deal with. As far as your sacrum and your coccyx, just mostly that's going to be fused bones, especially in adults. So we don't really count all the differences in them, but yes, there are extra bones in those. And the easiest way to remember that is we eat breakfast at 7, lunch at noon or 12, and dinner at 5. So 7, 12, and 5. That's your vertebrae counts going down. And different ones will have different nerves coming out of them. C1 and C2, for example, which is up these two red, very wide. They're bigger than the rest of the cervical vertebrae. The nerves that come out of those actually control your vital organs, like your heart, your lungs, that sort of thing. So if we have a fracture there, somebody's respiratory drive gets shut down, for example, and then they'll fall out. And I've actually seen that happen where they get up and they're like, look, I can move my head. I'm okay. And then they pinch the cord and suddenly they're on the ground unconscious. And we're having to bag them because they no longer have a respiratory drive. As you go down from there, you start to get more into other organs and also your movement nerves. So the ability to stand up. As you get down into your lumbar, you start reaching like the nerves that go to your legs. So if there's a fracture in the lower back, people might lose feeling in their legs, that sort of thing. Oop, wrong way. All right, your thorax. This is mostly your rib cage. This also includes the thoracic vertebrae. So you have 12 pairs of vertebrae, and each set has ribs attached to it. And these just protect your vital organs. Mostly, like I said, they're going to protect what's in your chest. So your heart, your lungs, your esophagus, the lower portion of it at least, and your great vessels, the superior inferior vena cava, the aorta, those large vessels that run directly to and from the heart. All right, for your appendicular skeleton, these are your arms, your legs, their connection points, and the pelvic girdle. These joints occur whenever bones come into contact, and this is what allows us to actually move. So wherever the joints are here, you really don't see a lot of fused joints, right? You've got the joints in your lower extremities, your knees, your ankle, they're movable joints. Same as in your upper arms. Most of your fused joints in your in your appendicular skeleton are going to be in your pelvis. Your iliac crest, all that butterfly looking set of bones, those are actually a couple different bones that are fused together. You don't need to know each one, but just something to point out. This part of the skeleton is mostly what gives us movement rather than protection. There's 2 types of joints that you're going to deal with. You have your hinge joints, which are like your elbow and your knee. This allows for rotation and bending. And you also have your ball. That's your hinge joint allows for movement. Looked at the slide at the wrong place. Your ball and socket joint, that's going to be where your legs connect to your pelvis at the hips. It's going to be how your arms connect to your shoulders, and they allow for full range of motion. It allows you to basically do like arm circles. You can swing your leg around, that sort of thing. Those are hard to stabilize. When we look at that from a trauma standpoint, it's not usually as easy as just putting a cast or a splint around it, right? We got to with the arms, it's not so bad because we just do a sling and swap. Legs are a little bit more difficult. We usually wind up really strapping somebody down and immobilizing the whole person to the board because that the legs are so big compared to the arms, it can get kind of hard to get it to where they don't move. And a lot of times, if they've actually messed up their hip, um, their leg, whichever side they messed up their joint with, that leg is going to be considerably shorter than the other leg, and it gets to be kind of hard with splints and things. We have a traction splint that we typically use, but the problem with that is you can only use it on a set kind of break, and if there's anything else wrong, we can't use it. Um, so we'll show you that at your boot camp, but you won't really do too much with it. Here's just a visual representation of your joints and how they move. Nothing really fancy, like I said. It's just so you have your ball and socket where your bone kind of fits into a crevice of other bones that make the joint, and it allows for the most part, 360-degree movement. You're usually only limited by the muscles themselves, and then you have your hinge joint on the right. Your upper extremities extend from the shoulder girdle to the fingertips. This is your arm, your forearm, hands, and fingers. So your shoulder girdle is where a few bones actually come together. It's not just one solid receiver and your humerus fitting into it. You have your clavicle, which is on the front. That's that bone that makes up the front part of your shoulder, and this is easy to break when you get hit there. That bone breaks a lot, and it's really painful. Like I myself have been fortunate to never break a bone, especially that one. But as far as broken bones go, from people I know, that's probably one of the worst ones to break. You have your scapula, that's your shoulder blade. That's a funny bone because it doesn't actually lift or bend, it just slides. But that's what allows you to move your shoulders forward, move your arms forward, that sort of thing, so that you still maintain shoulder integrity while you're trying to get motion out of your shoulder. And then you have your humerus, that's the upper bone. It's right between your bicep and your tricep. And that bone is it's just like your lower legs in that your proximal portions, your upper legs, your upper arms, you have one bone. All right. For the arms, that's going to be your humerus. For the legs, that would be your femur. Now, we already talked about the humerus. This is your supporting bone. Your forearm is attached to that. You have your radius and your ulna for your forearm. Which one's on the thumb side?
I think it's the ulna, isn't it?
It's not the ulna. The thumb side is actually which to make it easy, when you feel a pulse, if you're going to check somebody's pulse on the wrist, you put your fingers on the thumb side. The reason we call it the radial pulse is because it sits over the radial bone. The ulna is actually on the pinky side. So I know the slide says lateral and medial. So to put that into context, when you think about the anatomical position, you've got the picture of the guy with his hands down by his sides. The palms are facing forward. So from what we learned on Thursday night, medial is closer to the midline. So from that position, your pinky is actually closer to your midline than your thumb. So the ulna is on the medial side, the radius is on the lateral side. Here's your hand. You just have carpals, metacarpals, and phalanges. Now they do have, each one of these has names. Again, by no means have to know that. In fact, I really don't even mind if you don't know anything past carpals. The only thing about carpals is you may get a patient that tells you they have a history of carpal tunnel syndrome. That's going to be in the wrist. Your carpals are just a group of square cube-shaped bones that kind of form like a bracelet. And all your blood vessels, your nerves, and your muscles for your hand run through there. So people that start spending a lot of time typing, for example, they start to build up their muscles in their fingers or from finger use. But the problem is that the muscles that actually move our fingers are not in our fingers themselves, right? These are long, thin muscles that connect at the wrist, run through our palm, and then all the way up there, like very long, thin muscles, and the connection points, the tendons are pretty much the lengths of your fingers, and that's why when they contract, they pull your fingers down. If the muscles were actually in your fingers, when you tried to bend your fingers, they would just get bigger. As they, as they pull in, instead of being long and thin, they'd be short and fat, and then they'd be in the way. You wouldn't be able to close your fingers all the way. But the problem with that is that as those muscles get stronger, they get bigger, just like if a guy were to go to the gym, and then you start to run out of space in that little tunnel that the carpals create. And then that presses on your nerves. That's why we get carpal tunnel. Sometimes they can fix that with just a wrist brace. Sometimes they need surgery. But most people know what that is these days. Back when I was a kid and typing was kind of new because not a lot of people had keyboards. I mean, I'm not that old, but old enough that we didn't have computers in the houses very much. Um, Carpal tunnel was just getting to be more popular or more common. So a lot of people weren't sure why their wrists were hurting. All right, for your pelvis, working our way down the body. This is a closed bony ring consisting of 3 bones. You have your sacrum and then 2 pelvic bones. Those pelvic bones are made from different bones that are fused together. But again, I don't expect you to memorize those things. You have your ilium, your ischium, and your pubis. Those are the pelvic bones. And the only thing that I really want you to know is to see the ilium. I'm sorry, the top of the ilium is called the iliac crest. So that's kind of an important landmark. You may see that pointed out in a test. Just know that that's the top of the hips. So if you put your hands on your hips right above, when you press down, that's actually what you're feeling. All right, anteriorly, the right pubis and left pubis are joined by the pubic symphysis. This is a hard, bony, and cartilaginous joint with minimal motion. So if you look at this down at the very bottom center of this picture, that pubic symphysis, that is where it connects. Sometimes people will break that, and like if it's a motorcycle accident, you'll see people that have broken it. Horseback riding can do it if you're in an accident there. If you've ever fallen, like straddled something and fallen on it, you see people do that in like gym fail videos. And then, as funny as it is to watch, sometimes the injuries can be pretty bad. If they break that, their hip integrity will be gone, and you'll see. Whereas, like if a normal person were to kind of spread their legs out, like in a split, the hips still stay in place. They don't fan out with the legs, right? But if you were to break that, that could happen. You could imagine your legs coming out, but your hips coming out with it. So the reason I point that out is when we get to the point of boot camp, or even just talking about your trauma assessment where you're doing 4-point push pulls and you're checking for bone integrity and stuff, especially in these areas, when you check the hips, it is a squeeze in. You're pushing inward from the hips, and you're going to do a soft rotate down, and that is it. Don't grab like left and right side and try to twist in all different ways, because if it is broken, you're on the high risk of cutting blood vessels. You can see your aorta splits off into your femoral arteries right there. So does your inferior vena cava. If you break those, the person could bleed out without ever even losing a drop of blood to the ground. So checking the hips, if you do it wrong, it can be dangerous, but it's just a very quick, you squeeze in. If you don't feel any motion or any give in the muscles, you're good with that particular portion. And then we rotate down, like if they're laying on their back, we're just basically pushing toward the floor a little bit. And you shouldn't feel any motion in the bones in either direction. For your lower extremities, you have your femur, which is your thigh bone. This is the longest and strongest bone in the body. This is a huge bone. And this is the bone that if they break it, this is what the traction splint's for. It's supposed to be used to kind of fight the quads and your hamstrings and pull the bone back to where it needs to be, which is great. The problem is because of how strong this bone is, usually if it breaks, there's also going to be a broken ankle or like a fractured hip, something of those lines, which makes it to where we can't use a traction splint. They used to drill it to where like when I went to EMT school, when Brad went to EMT school, all that stuff, we had to be masters of this splint because you just, oh my God, EMTs got to know how to put this traction splint on because it's what's necessary for a femur break, even though we really never see it used in the field because there's always some reason why we can't. Eventually, they finally decided that maybe they don't need to drill it as hard as they used to because we almost never get to use it. But we'll still show it to you. At the superior head of the bone is the femoral head. This is a round ball-like structure, and that's what fits into the hip so that your bone connects, your leg connects to the rest of you. The femoral head attaches to a shaft of the femur through the femoral neck, and it looks like a neck. So you have the ball, the femoral head, then it gets short or at least it gets thinner as it goes down to the actual length of, the main shaft of the femur, and then it gets wide again for the bone itself. I'm not going to bother teaching you the greater and lesser trochanter. You really don't need to know that. That's above and beyond for EMT. For your knee, this connects your upper and your lower leg. This is a hinged joint. You actually, if you were to try to, if you put your leg out in front of you and you try to move your foot left and right, you'll notice that your knee doesn't move. It's not designed to move that way. That's actually your hip doing a rotation. So that being said, if somebody's upper leg, and you see this in football all the time, if somebody's upper leg gets trapped as they're falling to the side, they'll pop their knee out of place because there's no other way for the leg to adjust. The hip can't compensate for it because the upper leg is stuck. The lower leg moves, and then they kind of pop their knee. That's pretty painful. There's a lot of stuff that goes on in the knee. That's a big, even though it's just a one-directional joint, there's a lot of things that play into that because it's a load-bearing one-way joint. It's designed to carry your body weight and then whatever you're carrying on top of that. So when those break, it's usually not pretty. Your lower leg is your tibia and your fibula. And this one actually says the tibia is the shin bone. The fibula is on the lateral side of the leg. Let's see if there's a picture. Nope. Okay, unfortunately not. So one of these bones is thicker than the other. One's pretty thin. Can anybody tell me which one is your load-bearing bone? Is there? Oh, there's a pick in the book. Okay. Yeah, your tibia is your load-bearing bone. The way that I always remembered that was that the fibula is feeble, so it's not meant to pick up your body weight. The fibula is just designed for you to rotate your toes and like move your foot, either rotate it inward or outward. If you break your tibia, you typically won't be able to stand up because you can't bear weight. If you break your fibula, you could potentially stand, but being able to walk or change directions while walking would be almost impossible. That's where you're going to get the shooting pain, probably fall over because you lost balance, that sort of thing. Your ankle, technically, it's a hinged joint. Even if you tried to rotate it all the way around, you would find that it kind of, in certain spots, it would kind of jerk a little bit. It's not a smooth rotation, like as if you were to do a 360 with your arm. It's because the ankle joint itself is a hinge joint. There's some additional joints in there that help it rotate in different directions, but you're actually going to rotate between, or going to go between two different joints to get full rotation out of your foot. All right, for the foot itself, just like your hand is called, or your hand bones are called tarsals and carpals and metacarpals, your foot is tarsals and metatarsals. So just one letter difference. The main thing that I want you to know is that your calcaneus is your heel. All right. And other than that, none of the terms you should really ever see on a test or anything like that. And again, in EMS, because we don't have x-rays, we don't bother getting down into the specifics of the bones of the foot because we don't know which one it might be, right? Somebody breaks their heel, we pretty well figure that one out. We don't need an x-ray to say that it's that versus a metatarsal. But when you get down into the foot itself, it gets kind of hard to tell. For your physiology, Like we said at the beginning, the purpose of the skeletal system is to give the body its shape. It protects your fragile organs, particularly in your chest, allows for movement, stores calcium when you need it, which is great because your heart needs calcium, your muscles need calcium, and it helps create blood cells. All of those is not just for movement and protection. A lot of your electrolytes are stored or come from the bones themselves. For the musculoskeletal system, this is what allows us to move. It allows us to stand up. It does protect your vital organs because remember, your ribs stop at the bottom of your chest. So your muscles are what protect your abdominal organs. There's no bones there, mostly so that we have the ability to move. If our rib cage went all the way down to our hips, we wouldn't be able to bend over or any of that kind of thing. We have 3 different types of muscle. You have skeletal muscle, which is what we can control. That's if you work out in the gym, most of your muscles that allow you to move, biceps, triceps, quads, those are pretty easy to remember. You have your smooth muscle, which is going to be your blood vessels, your intestines, your esophagus, bladder. Those are smooth muscle. And then you have your cardiac muscle, which is found in the heart. The muscles that I want you to remember here, mainly are just going to be actually, I don't think there's any test questions that involve these, like knowing the names. If you're not sure about any of them, obviously you can use your book, use this picture, but just knowing what the skeletal muscle is typically is enough. Contraction and relaxation of the system make it possible to move and manipulate the environment. Your muscles can only contract. That's why we have muscles on both sides. Like if I want to pull my arm in, my tricep's not doing anything. It's just relaxing. My bicep is moving the bone. If I want to straighten out my arm, my tricep contracts, straightens it out because my bicep relaxes to allow it to happen. And a lot of the systems in the body operate the same way. They're one direction only. That's not so. It's cool to know for muscles, but unless you're like a personal trainer, it really doesn't pertain, I guess you could say. But with the neurologic system, for example, which we'll get to, that's got some aspects of it that are also one way, and that really does matter because if we break our spinal cord in a certain spot, we may lose access to one side of it, and then the other side just takes off running. And you'll see that in their vital signs. You'll see that in how they react, if they even stay awake for you or any of that sort of thing. But the other good thing about your muscles is that they can help you shiver. So if you get cold, your muscles will start to kind of quiver, which allows you to shiver and create heat through friction, and it warms you up. If a patient is completely unconscious, they lose that, which means that if you're in a cold environment, you might have to help them stay warm, cover them up, that sort of thing. Babies actually don't have that system in place at all. An infant up to a first year or so of life, y'all should have already done by now lifespan of development. But babies don't shiver. They have a different process for creating heat, and as long as they're hydrated, that process usually works. Whenever a baby gets dehydrated, either by not drinking enough or if they get sick and they're vomiting a lot, they can get dehydrated. They run the risk of not being able to maintain their body heat anymore, and then they get hypothermic. So that's just something to think about. As you get older, you do have that shivering process, but if you're dealing with an infant, they don't. So it's that much more important to try to keep them wrapped up, keep them warm. All right, for the respiratory system, this is how we breathe. We have your airway, which is broken into your upper and lower, and then the dividing line is the epiglottis. That's where your vocal cords are. So you as EMT basics, y'all are going to learn how to use airway adjuncts and airway insertion devices like the King airway, the combi tube, that kind of thing. Those are blind insertion. You can use them as EMT basics because they don't go past the cords. Those are only good for the upper airway. Same thing with your OPA and your NPA. If you go on to be a paramedic, you're going to get the advanced airways that actually is like an ET tube where you go past the cords and then you inflate a balloon that holds it in place. And that's something that's out of our scope as EMTs. So, like I said, the easiest way to look at it is if you don't have to pass the cords, typically you can use it, and we'll train you to do so. If it does go past the cords, that's an advanced provider. So, if you get a patient with an airway problem, you think you may need a device that goes past the cords, you're going to have to get a paramedic out there real quick. But your upper airway, that's your nose and your mouth, which is your oral cavity. Those two connections are pretty much shared. You have your tongue, which sometimes causes some issues with patients when they lose consciousness, your jaw, and your larynx. All right, like I said, the trachea is where the epiglottis is at. That's your vocal cords. For your lower airway, now we're moving past the cords. Your thyroid cartilage, which is your Adam's apple, is very apparent in males, forms the anterior portion of the larynx. Tiny muscles will open and close those vocal cords and control tension. That's how we talk. If you've ever done the whole, swallow a bunch of helium thing and then sound like a chipmunk, that's because the helium has paralyzed your cords. They still vibrate when you try to talk, but they can't adjust their pitch. They're just kind of stuck. And then that's why your voice is as high as it is. You have your cricoid cartilage. This is immediately below the thyroid membrane, and that's an important landmark for us because if we're assisting a paramedic with putting in a tube, he may tell you to press on the cricoid, which is called giving cric pressure. That when you do that, if you imagine your epiglottis being shaped like a football, your vocal cords, they attach at the anterior and posterior side, so they look. You look at it like top and bottom, and then the cords kind of fan out a little bit on the left and right sides. If you press on their cricoid cartilage, you're basically taking that football and you're pressing down on one point of it, which causes the bend to get a little bit more, and it gets more into like a diamond shape. So it opens up the cords enough for a paramedic to push the tube through. That's just below the Adam's apple. All right, for your trachea, this ends at the carina, and this is usually what you picture when you see in fact, let's see if it's on the next slide. Nope, of course it's not. Your trachea goes all the way down to where it branches off to each lung, basically. So when you're looking at a picture, the one airway tube that runs down, that is your trachea, and then it branches off into your left and right main bronchi. You have two lungs, obviously. Well, I say obviously, if somebody's lost a lung, that's different, but they're held in place by the trachea. Arteries and veins will hold them in place from the pulmonary system, and then you have your pulmonary ligaments. Each lung is divided into lobes. You have 3 lobes on the right and 2 lobes on the left. Can anybody tell me why we only have 2 lobes on the left?
Because your heart's on the other side.
That's it. Yeah. So the heart technically hangs out in the middle, but that is exactly it. Your heart angles to the left as it goes down toward the apex. And so it's just a matter of real estate. There's not enough room for the left lung to have 3 lobes. So it's only got 2. Within the lobes, you have your bronchi and your bronchioles. It's basically your left and right main stem bronchus are getting smaller and smaller. They're branching off more and more. And they're going to eventually end in small grape-like sacs called alveoli, which I always thought looked more like broccoli than grapes, but that's what they say. And your alveoli is what allows for the gas exchange to happen. That's where your oxygen goes into the bloodstream, carbon dioxide comes out. And I think I saw, yeah, here we go. Had to back up a couple slides. So if you look at this picture at the bottom right, that's your alveoli. The pulmonary arteries and veins eventually go down to capillary beds that basically wrap around each one of those bulbs. And in a healthy person, those bulbs are well defined. They're they look like they do in this. And so you have a lot of connection points for those capillary beds. If you have a patient with emphysema, for example, however, those bulbs start to kind of expand out. They get more, it becomes almost like one giant bulb with a couple of blobs in it. They're not as well defined. And with that, you lose surface area for those capillary beds, which means that even though your patient is still breathing in and out, with less connections for capillary beds, there's less spots to have that gas exchange. So they're going to have a harder time keeping their O2 sats up, because even though they're taking in the same breath size, less of it is being absorbed into the bloodstream. Less carbon dioxide is coming out too, and that's going to make a difference when we start talking about patients' O2 sats. We're eventually going to teach you guys about entitled CO2, how to deal with patients with COPD and emphysema, and knowing that anatomy will help you understand why patients with emphysema may have a 92% O2 sat and that be okay. All right, let me get back to where we were. Okay, so your pleura, this is a layer of smooth, glistening tissue that covers each lung, and it basically provides lube, I guess is the best way to put it. It keeps everything smooth so that when you breathe, you don't feel it, right? There's no friction created. It's smooth, it's effortless, as long as that pleura is there. If there's ever a spot where the pleura starts to kind of dry out, then when you take a breath, you do feel the friction and it hurts. And that's called pleurisy. If you have a patient that's got a problem with that, you'll notice that they tend to breathe really shallow, because if they take a deep breath, it's going to hurt real bad and they don't want to do it. And then with that becomes trouble breathing, because they're almost willfully not breathing like they should be, because of the pain. But it is beyond their control, because unless they're completely unconscious, they're just not going to take a deep breath, and then they're not going to get good oxygen exchange. So the muscles involved in breathing, there's a couple. The main one is the diaphragm. This also divides the thorax from the abdomen. So this kind of sits underneath your ribs, and it's got a downward curve to it, or at least it looks like a frown, I guess you could say. So that when it contracts, the diaphragm actually drops down. It doesn't contract up or anything like that. Other muscles involved, you have your neck, your abdominal muscles, and your pectoral muscles, your chest. Those are called your accessory muscles. If you ever see patients having to struggle to breathe, you'll notice like the skin around their clavicles will suck in. Their neck will kind of crunch a little bit. That's not normal. If you walk in and you see a patient that's doing that, that's a major sign that they're having a hard time breathing. And that's something that we need to try to fix as quick as we can. The way the muscles work and the way that we breathe, there's a difference between ventilation and respiration. Ventilation is the movement of air in and out. That's a physical thing. Respiration has to do with the gas exchange at the alveolar level. So if you take a breath and you pull air into your lungs, that's ventilation. All right, but that's not the critical thing. Even if you've got that, but for whatever reason there's no gas exchange, when you breathe out, you breathed out perfectly good air. You didn't actually get any oxygen from it. But again, the way that the muscles work, diaphragm drops and your chest will rise up. And that's what we look for a good breath, is chest rise. What that's doing is that's causing a drop in pressure in the chest, which allows the atmospheric air to just kind of fall in. All right, so we basically breathe by negative pressure. We're not pushing air into our lungs. The air just kind of falls in. And then when we breathe out, the diaphragm relaxes and comes up, the chest falls, and that chest cavity gets smaller, which puts more pressure on the air that's now in there, and it pushes the air out. The respiratory system's function is to provide the body with oxygen and eliminate carbon dioxide. There's a balance to that. So we don't want to get rid of all the carbon dioxide. The carbon dioxide in our body is acidic, and we like to keep a certain pH. So We won't get into that just yet, but just know that your body tries to maintain it. And that's actually why we breathe at the rate that we breathe at. If we need more carbon dioxide or if we need to raise our acidity, we'll breathe slower. Our body just naturally does it. We don't have to think actively about how fast we need to breathe, right? It's always been just like a body process. You can control it to an extent, but even if you tried to override what your body needs, it will make you breathe, even if it means making you pass out first. It's gonna like I've had patients that are like, I'm just hold my breath. Okay, let's see how long you can do it. Um, if you're conscious, your body will override you. If you're unconscious, typically you obviously now you no longer have that voluntary control. Your body gets to make the decision for you, and it's going to do it based on what your CO2 levels are. Um, whenever they get too high, the body will increase your respirations. You blow off a little bit more CO2. As soon as you get those levels down, then your body slows your breathing down. All right, so we're getting into, I kind of jumped the gun a little bit when I talked about the difference between ventilation and respiration, but that's what the slides are getting to now. Ventilation, as I said, that is the actual movement of air in and out of the body. Respiration is the gas exchange. So you need a couple things to make the actual respiration happen. First of all, you need blood, right? Because that oxygen's got to have somewhere to go. You also need something to carry that CO2 to the lungs. You don't just need blood present, you need blood moving. That's why it's important if we're doing chest compressions on somebody that's in cardiac arrest, it's more important that we do the compressions rather than just the breathing. Anybody that's taken AHAs or anybody's really CPR in the last few years, you've noticed they've put compressions first. It's because you have to have that blood flow. If the blood's not flowing, then there's nothing to make the oxygen go round and round, right? You can breathe into them, but it doesn't do anything if the blood's not moving. All right, we'll skip that. It really isn't that important. The medulla, the brainstem, that's what controls your breathing. It's also what controls your heart rate. The pons has two areas that help augment respirations during emotional and physical stress. So if you're stressed out, sometimes, or if you have a head injury, if anything happens that activates the pons or puts pressure on the pons that shouldn't, be it that you've got like pressure building up in the head, and we got a chapter devoted to that way down the line toward the end of the class. That can cause a patient to start breathing way out of range of what the body actually wants. Because even though, like I said, CO2 levels are what guides our breathing, if something goes wrong, either in the neurologic system or if you're overly stressed, sometimes you'll, like an anxiety attack, for example, you'll start to hyperventilate. And with that means you're lowering your CO2, but you're not doing it because you're trying to maintain that physiologic level. You're doing it because you're freaking out or you got hit in the head. And so now you're causing more problems. People that do that, they'll notice their fingers start to tingle. Um, it doesn't work out for them, and they start to have other problems. If you blow off too much CO2, your vessels actually constrict, which will mess with your blood flow. Ventilation is the movement of air. All right. So let's talk about dead space. This is what allows us to give breaths to somebody in CPR and it still be a good breath, right? The only air that becomes carbon dioxide when we breathe it out is the air that made it to the alveoli. All that space on the way, your bronchioles, your left, right, mainstem bronchi, your larynx, your pharynx, all that stuff. That's air that comes out just like it went in. So if you're having to give mouth to mouth to somebody or mouth to mask or whatever, when you breathe in or when you breathe out to give them a breath, you're giving them your dead space air first, which is good. That's normal air. Let me get to the right spot here. All right. Minute volume. So there is a formula to this. You can see it on the slide. The thing about minute volume is this is what determines whether or not somebody's getting good breaths. If we show up to a patient and you see them breathing a certain amount of times a minute, which the normal adult breathes 12 to 20 times a minute, as long as those breaths are a good depth, then typically they're going to be fine. They're going to have a good minute volume. But if they're breathing, say, like 30 times a minute, and it's really, really shallow, they're not deep breaths, that kind of thing, then they may get a minute volume that's not really that well. Other end of the spectrum, they may only be breathing 6 times a minute, but it's really deep breaths. It's great that it's deep breaths, but if it's only 6 times a minute, you may still be too low. So our goal, whether the patient's doing it on their own or whether we have to do it, our goal is to make sure they maintain a good minute volume. And there's not a set number for that we need to maintain. So I don't want you guys to get hung up on the math of this. Just understand that, you're looking for 2 things. When we start teaching you vital signs, it's not just about the numbers. You want to make sure that it's good quality as well. If it's not, then we have to provide it for them. So when we get to the point of your assessments, and I'm asking you, how do you want to deliver oxygen to your patient? Do you want to let them breathe it in on their own, cannula or a non-rebreather? Or do you want to give it to them yourself using a bag valve mask? It comes down to, do you think that their breathing is adequate for them to manage it on their own? If they are, then fantastic. You just, put a cannula on their face, let them breathe oxygen, and you're good to go. If their rate or their depth is not where it needs to be, then we need to provide it ourselves, which means you're going to have either yourself or somebody else is going to have to do what we call bagging them, which is where you use a BVM and you breathe in for them. All right, for normal breathing, normal rate and depth, this is what we call tidal volume. It should be a regular pattern. Clear audible breath sounds on both sides of the chest. So if you take your stethoscope and you put it on the left side versus the right side, if you only hear breath sounds on one side, that's a problem. You should be able to hear it the same on both sides, front, back, top, bottom, all that. And then you're going to have regular rise and fall movement on both sides of the chest. So another sign that somebody may have a problem with their lungs is if they take a breath and only one side of the chest rises. It sounds like something you'd never see, but if somebody popped a lung, then that would be how you would know, because both lungs inflate together, right? And that's what makes your chest rise. If one lung has a hole in it and it can't inflate, then the other lung is only going to lift one side of the chest, and you'll see that. It's a weird kind of look. It looks like they're almost like they're starting to roll over, but their shoulders aren't moving. If you see movement of the abdomen, it depends. Children, like babies, they're belly breathers. Their intercostal muscles around their ribs haven't really formed well enough to do a chest rise per se, so their bellies are going to be what moves in and out. What you don't want to see is what we call seesaw breathing, where as the belly comes up, the chest goes down, and then when they breathe out, it reverses. That seesaw movement is bad, but it's okay to see the belly rise. That's not a problem. That's normal. Inadequate breathing. Some of these, and these are mostly just signs, right? You have labored breathing. Again, breathing should be effortless. So if you see them propped up with their hands on their knees, leaning forward in what we call the tripod position, and they're gasping for air, or they're only talking in 2 to 3 word sentences, things like that, that's a major sign that they're having a hard time breathing. These are things you can typically see across the room. Pale, cyanotic, cool, damp skin is a sign of trouble breathing. So cyanotic being the color blue, right? Cyan. The tripod position, like I already mentioned that, and then agonal gasps. You'll see that when patients are going into cardiac arrest. If they have gasping breaths where it looks like they're trying to bite the air as if it were solid in front of them, usually that happens because blood flow has stopped. All right, the heart stopped beating, the breathing is about to come to an end as well, and those last couple of breaths are just the body's last ditch effort to get something in. So it just looks like they're taking a bite out of dry air. The first time I saw that, I wasn't sure what to do with it. I was like, dude, what is this? That was right when I became a firefighter, and I had to have it explained to me because I hadn't had any training yet. Any questions on circulatory system before we move on to cardiology? Cool. All right, actually, we've been at it for an hour. Take a 10-minute break, and we will pick up with cardiology when we get done with this. So 10 after, and we'll resume. All right, I know I said 10 after, but it's close. It wasn't quite top of the hour when we took the break anyway. So we're gonna get back at it, and this particular portion of anatomy, I'm gonna try my best not to go complete nerd mode on y'all, um, because I love cardiology and everything to do with it, and I can very easily make people's eyes gloss over if I don't watch myself. So this and the airway chapter are probably going to be the most in-depth chapters or in-depth body systems that you need to know, because almost all of your medical calls are going to revolve around one of these two systems. Most people call because they have trouble breathing or their chest hurts. Heart attacks are a thing, obviously. And a lot of what we deal with at EMS has to do with those two things, not to mention your entire primary assessment has to do with these two systems. So I want you to know them very well. If that means putting the skeletal system in the back seat, that's fine, especially for now, because you're not going to deal with trauma until toward the end of the class. But anyway, the circulatory system, or what we call the cardiovascular system, is a complex arrangement of connected tubes. They are basically just the highways that move your blood around your body. So you have arteries, which carry blood away from the heart, and you have your veins, which move blood back to the heart. I know that when I was in high school, we always got it in our head that arteries carried oxygenated blood and veins carried deoxygenated blood, but that's not always the case. There's an exception to that rule, which we're going to talk about. So don't fall in for that trap. All right. Just know that arteries go away from the heart. They're very flexible. They're designed to manage the incoming systolic pressure from the heart, right? So they swell up easy. They're rubbery. They usually are stretched out under a lot of pressure, which is a good thing, even because especially if let's say you cut an artery, a lot of times the artery will actually seal itself off just by the nature of how it's built with the pressure of the blood in it and everything. If it ever severs completely, that's a much more serious issue. You usually wind up fixing that with a tourniquet until you can get them in the hospital, and then surgery can fix them. But we have two circuits. You have your systemic circulation, which is the vessels that go out to the body and the head. And then you have your pulmonary circulation, which is the system that carries blood from the heart to the lungs and then back again. So here's a very simplified layout of your cardiovascular system. Now, remember I told you that arteries carry blood away from the heart, but not necessarily oxygenated blood. Can you tell me from this picture which arteries carry unoxygenated blood and why? If you notice the arrows, there's one set of arteries that the arrows are actually pointing back toward the heart. Oh, that's fine. So I said, I don't know if you can see the picture if you're using your phone, but there's one set of arteries that carries blood, carries unoxygenated blood. Yeah, Thurston, you got it. You put it in a private message. Okay. Yep. So the pulmonary arteries, good job, Thurston. Like I said, you got it. So nobody else could see it. The pulmonary artery is sending blood away from the heart, but it's sending it to the lungs because it's got to pick up the oxygen. So your pulmonary circulation, when it comes to oxygenated versus deoxygenated blood, it's backwards, right? The blood going away from the heart in the artery is actually deoxygenated. That's why that artery looks blue. And then the pulmonary veins carrying the blood back to the heart are red because that's just how we color our oxygenated blood. When the blood gets rich with oxygen, the hemoglobin turns red, and it makes your blood be bright. Deoxygenated blood typically is like a darker. It isn't blue per se. It's just not bright red. But before I change this slide, I want to show you the heart has two systems to it. All right, you've got the electrical system and the hydraulic system, and the electrical system tells the hydraulic system how to work. So, but from this picture, this is the hydraulic setup. This is how your blood moves through. If you look at your heart, the right side of the heart, which is actually the left side of this picture, because this is from your patient's perspective, not yours. Blood enters the heart into the right atrium. That's that top left blue square. All right, your inferior and your superior vena cavas dump into that. That chamber dumps into your right ventricle. And then the ventricle is what pushes it out to the body. If you notice, the left ventricle has smaller musculature. It's not a smaller vessel. I'm sorry, it's not a smaller chamber. It's just smaller muscles. The reason being is because it doesn't have to go that far. It's only going to the lungs. So that chamber doesn't have to push as hard. It goes from the right ventricle through the pulmonary arteries out to the lungs, and it picks up oxygen to come back through the pulmonary veins to the heart to be sent off to the body. And on that side, it goes into the left side of the heart, which is on the picture is on the right side. The right atrium collects the oxygenated blood from the pulmonary veins, pushes it into the left ventricle, which, as you can see, has a very much thicker musculature wall. The left ventricle, when it compresses hard, and it shoves that blood all the way through, because that chamber has to push blood not just to your head, which isn't that far away, but it needs to push it all the way to your toes. So it's got to have a lot more force to it. When you feel the heartbeat, like if you're going to check somebody's pulse, it's the left ventricle that you're feeling. That's what's pushing that blood through. All right. So for the heart, like I said, this is a muscle. It's usually, I think it's about the size of your fist is what everybody always approximates it to. It's made of specialized cardiac muscle. The cool thing about cardiac muscle is that every single cell within the heart is capable of creating an electric charge to make the heart beat. That is fantastic because you've got almost an unlimited number of backups if your SA node fails, which we'll talk about in a little bit. The problem is when those things start firing off when they're not supposed to, because then you have a problem. If one cell fires off, the cell next to it will take that charge and fire off one of its own. So if you've got, a cell on one side of the heart decides that it's going to beat out of order and it sends off a charge, that means that part of the heart is going to start to contract. If you have another cell on a different side of the heart that does the same thing at the same time, then that part of the heart's going to start to contract. And if it gets too disorganized where everything's just kind of trying to do its own thing, your heart's going to quiver, right? There's actually a name for that. We're going to talk about different rhythms that you need to know as EMTs. That's one of them. The problem is that without that organized rhythm, the heart can't really give a coordinated beat. All it does is it just shivers. So the blood that's in the heart stays in the heart. You lose your pulse, which leads you down the CPR route because you don't have a pulse. Now the good thing is that that's corrected with an AED. Which is why they try to put the AED first. And when you're doing cardiac arrest calls and you're running those CPR codes, even as an EMT, or if you go into paramedic, same thing. Those calls, you want to try to get the AED on them as quick as you can. Almost all cardiac arrest calls start as electrical. So if you can get the AED on there fast enough, you might be able to shock them back to normal before you even have to really start pressing on the chest. Okay. Yep, you're close. Well, it's not just AFib. It could be VFib as well. In fact, VFib is what we shock. AFib, people tend to live with that one. That's where the atria are fibrillating. So the atria are fluttering and quivering, but the ventricles are still beating okay. That's not something we would shock, but it does come with its own set of problems, which we're going to talk about when we get to the actual cardiac emergencies chapter. But yeah, you're right. As far as the quivering part, that is the same. All right, each side of your heart is divided into two upper and two lower chambers. Your upper chambers are the collection points from either the body or the lungs. They're called the atria. Just like if you have an atrium of a building, usually that's that first little room you come into when you walk in the front door. That's the same concept here. Your ventricles are the bigger chambers at the bottom. They're the ones that actually shove the blood out of the heart, going to either, like I said, the lungs or the rest of the body. And then your septum divides the heart into right and left. As an EMT, that's just a landmark. All right, you really don't need to know anything else about that. If you guys go on to paramedic, we start talking a lot more about the septum and what's inside of it. But as an EMT, just know that as being the center of the heart that separates the left and right sides. For the circulation itself, the heart receives its blood from the aorta. I know that sounds a little weird, but your coronary arteries are actually, they come off your aorta right at the very beginning. Those tiny little arteries take the entrance to them takes the bulk of your blood pressure. But the biggest beat closest to the heart, which means the most pressure is right there. Why don't they blow away? Your coronary arteries are very thin, very small. Why doesn't just a regular heartbeat just completely destroy your entire coronary circulation? Then there's a reason I asked this. Backflow. Okay, so you're on the right track. What stops the backflow? It's the same thing that stops all that pressure from blowing the arteries away. The question is, what stops all that massive pressure of the aorta from completely obliterating your coronary arteries? Because your coronary artery begins at the base of the aorta, where all the pressure is at its max. Okay, yep. So the valve that leads to your coronary arteries is very, very hard to open. It takes a lot of blood pressure to open that valve to get any blood in. And the only reason I really want you guys to know that is because think about when you were taught CPR. And we give you all the numbers, and you're like, well, I just got to memorize 30 to 2. And why does 30 matter? A lot of people will discount things like that because they don't think there's any real rhyme or reason to it. The reason that we say 30 and they harp so bad on don't interrupt your compressions, you have to make it to 30 or as close as you can. If you come up on a patient in cardiac arrest, be it you as an EMT or John Smith, the Walmart employee, it really doesn't matter. If you're going to do CPR on somebody, if they're in cardiac arrest, they really don't have a blood pressure, right? And if the problem is cardiac related, especially if it's an ischemic heart attack, which means that their heart's not getting any blood flow, not the mitral valve, that's within the heart itself. I'm talking about the valve that separates the coronary artery from the aorta, which is on the aorta itself. If you start giving compressions, every compression, or at least every good compression that you give, is going to bump their blood pressure up a little bit. And let's say you have to have a pressure of about, we'll just say 50. If you need a pressure of 50 to get any blood into the coronary artery, and it takes you 18 to 20 compressions to get that blood pressure to that level, and you stop at 15, 16, all of those compressions were wasted because no blood made it to the heart itself. You got blood around the body, sure, but if the problem's in the heart, then your compressions didn't do anything to fix the problem. And no, not the mitral valve. In fact, let me go back to that other picture. All right. So looking at this heart, because I see a couple of y'all are asking about the mitral. You have two valves that separate your atria from your ventricles. You have one on the left, one on the right. This one doesn't really do a good job of showing it. Maybe a picture later on is going to show you the actual tricuspid a little bit better. But the valve on the right side of the heart, which is the big valve on if you're looking at the picture, it's on the left side of the picture, that separates your right atria from your right ventricle. That's your tricuspid valve. All right, there's actually three pieces that form that valve and shut off. On the left side, on the red side, you see the same valve that separates the atria from the ventricle. That's the bicuspid valve. There's only two. The easy way to remember that is you're going to try it before you buy it. So it's the blood flows to the heart. It hits the tricuspid valve first, then the bicuspid valve on the left side. Your bicuspid valve is your mitral valve. That's the specific name for it. I always do bicuspid. It's just easier for me to remember because there's two flaps that make that valve up. That's not the valve that I'm talking about with the coronary arteries. The coronary artery valve, if you look at the aorta, when it comes up the top of the heart, right above the heart itself, that's where the coronary arteries come off the aorta. So I'm not talking that the mitral valve is down in the chambers. That's not the same valve. And I'd have to look it up. I'll be honest with you, I don't remember the name of the valve that leads to the coronary arteries, but it's a very, very strong, very, very strong valve. I don't think it's AV because that typically means atrioventricular, which would be one of the other two valves. But I'll get that. I'll get that and let y'all know. I'm not sure. I have to Google it, to be honest with you. I don't remember what it's called. But anyway, my main point being is that that valve is designed to withstand a certain amount of blood pressure before it opens. That way it doesn't let the full force of the aortic pressure blow all the coronary arteries away. If you're doing compressions, you have to build their blood pressure up to a certain amount before you get any blood into the coronary artery. It's normally a good fail-safe, but it's a pain in the ass if you're trying to do CPR. That's why we have to do so many compressions at a time. That's why they try to minimize how long between compressions, like when you're giving breaths, that sort of thing. All right, so this picture is just another picture of the heart. You can see, if you look down at the ventricles, you can see how I was saying the left side of the heart has the much thicker muscle because that's the side that has to push blood out to the body. It's the right side on the picture, but that's because your right and your left are reversed because this is basically the patient's left and right, not how you're seeing it. All right, so here's some vital sign stuff for you. We talked a little bit earlier about the respiratory stuff. So normal resting heart rate for an adult, 60 to 100 beats a minute. Now, different textbooks will give you different ranges for most vitals, but the heart rate is pretty constant. I've not seen any other textbooks give a different number. So 12 to 20 for an adult for breathing, 60 to 100 for an adult for heart rate. Those are pretty well set. Would that valve be called the leaflets or cusps? Not that coronary valve. Leaflets or cusps, those are the individual flaps that make up the valve. So like we were talking about tricuspid and bicuspid, the tricuspid has 3 leaflets or cusps. The bicuspid has 2 leaflets or cusps. So that's referring to the parts that make up the valve. Give me just a second. Buddy of mine sent me a picture. This may have the, no, it doesn't. I want if you can find it, I want the name of the valve for the coronary arteries. Hey, you know what? I'm right there with you because I'm gonna have to look it up. It's gonna bother me. Like I like cardiology that much. So, all right, moving on. Your stroke volume. This is how much blood you move in a single beat. All right, and this is affected by a few things. If you guys have activated your Master Your Medics memberships yet, there's a section in there on shock. We haven't really started talking about shock itself yet, but he does a fantastic job at the beginning that recaps cardiac output, stroke volume, and everything, because all of that lays the basis for how people wind up going into shock, like what causes it, where's the problem. And his review is way beyond what would be in this slide or in the lesson plan or any of that sort of stuff. Like it's really good. So I highly recommend checking that out, as well as the videos that they curate for you. Here we go. Well, I thought that would be it, but no, that's not it either.
What's the vessel? Looking down the 4 valves inside the vessel.
Yeah, but this is only the mitral and tricuspid. Those are going to be in the chambers. Your left coronary, it shows the coronary arteries, but not the valve that leads to them. There may not be a valve for it. I mean, I know there's a valve, but I don't know if they've bothered to name it. Could just be a valve. Anyway, so your cardiac output, that's the amount of blood you move in a minute. And again, just like how we were talking about minute volume, I'm not so concerned that you guys know the formula, but just understand the basis for how we figure this out. So your cardiac output is your heart rate times your stroke volume. So the amount of blood you move in a single beat times however many beats you have in a minute, that's your cardiac output. If one of those numbers moves up or down, your cardiac output is going to move up or down. And your body does that on demand, is always fluctuating. If you get up and walk around the house, your heart rate's going to pick up a little bit. Semilunar, see if that's it. Semilunar, one word. If you are sitting on the couch watching the game, and nothing major is happening, and it's turning into a soccer game where they're just punting to each other, your heart rate's going to drop. If your team's running down the field, well, that's different. All right. Anyway, moving on. So we're going to move to your electrical conduction system. This is what drives your heart. Now, I'm going to go much further into the electrical conduction system than what this is, because I bet that's going to jump straight to arteries. So your heart has a couple of different things that tell it how to beat. You have your SA node, or your sinoatrial node. That is the primary pacemaker of your heart, and it sits up at the top of your right atrium. That's why it's called the sinoatrial node. It's a sinus rhythm, or it's a sinus that sets a set pace. And when the brain tells the heart to either go up or down, it's telling the SA node to beat either faster or slower. So the SA node, you can look at it like if you're in a factory, that's your shop foreman. All right, he's the one that's in charge, knows what all's going on. Everything, the buck stops with him. He's got all the answers. When the SA node fires, it goes down some electrical conduits that wrap around your atrial, your atria, both of them. And that's called your intranodal pathways. Those atrial little routes will meet right between all four ventricles, right, like right below your atria, above your ventricles, in the center of the heart, above where the septum kind of comes to a close. That's your atrioventricular node, hence you get the name AV. And it gets its name because of where it sits. Again, it's atria above it, ventricle below it, so it's right between the two. They call it the atrioventricular node. From there, it travels down your septum very, very quickly through your bundle branches, and then starts again at the bottom of the heart, beating upwards. So that if you get a heartbeat, starts at the SA node. When it starts to hit those heart muscles, your contraction starts at the top of the heart. But obviously, muscle movement is much slower than electrical movement. So that electricity is traveling much faster than what the heart's actually beating and responding to it. By the time the atria get into their contraction very well, that electrical pulse is already down at the other end of the heart, coming back up. And so the ventricles are going to beat from the bottom. So you get that ba-dump sound when your heart beats. And it's the first half of that is the top beating down. The second half of that is the bottom beating upwards. So the heart actually contracts toward its own middle. I guess you could say the top beats downward, the bottom half beats upward. And that's what makes the blood flow through your heart. I won't get too much further in depth than that. I just want you to know what those locations are and how the electricity travels so that it can make the heart beat the right way. If the SA node is your pacemaker, right? So that's 60 to 100 beats a minute. That's what your SA node typically beats at. If the SA node fails, your AV node is the backup. I'm just trying to read to keep up, but that's all right. Hey, this lecture is recorded. You can always go back and watch it again if you want. You don't have to read along. You can just kind of follow the lecture and then read again later, or vice versa. Tune me out. That's whatever you need to do. This doesn't show it either. Yeah, I see it, semilunar. Okay, so no, it wouldn't be the semilunar. That's your bicuspid, it looks like. No, it's not. Semilunar, that's your aortic valve. Getting warmer. The specific valve at the beginning of the coronary artery. It's not actually inside the heart. It's just a valve coming off of the aorta. Anyway, so your SA node is your primary pacemaker. That's your shop foreman. It beats, of all the different pacemakers that are in the heart, it beats the fastest because the heart is designed to follow the fastest tick. So as long as the SA node is firing like it should be, yeah, I know, right? Call a cardiologist, still know. The heart should follow the SA node. If the SA node fails, The AV node is the first backup. It beats a little bit slower. It beats between 40 and 60. And I don't, it's okay if you don't memorize the numbers, you'll pick it up as we go. When we start talking about cardiac emergencies, we're going to talk about this more. I just want to give you guys the layout now since we're in the anatomy chapter. The AV node beats a little bit slower than the SA node. That's kind of like, shop foreman's out of the office, but his assistant's there. His assistant doesn't know everything the foreman does, but he knows he needs to get the job done. So he's going to get things moving, not as efficiently, but he's going to keep things going. If the AV node fails, then the heart itself, every cell, like I said, every cell is capable of creating its own charge. The reason that that's there is because if the two managers are out of the shop, the worker bees can actually create a pulse if they need to. Problem is that they don't have a lot of direction, right? These are the brand new people. They don't know really how the shops run. They just know how to do their one thing, and that's it. And without the leadership there, they're not exactly going to move that fast. So if you're down to those particular cells being your pacemaker, heartbeat is very, very slow. You're looking at a heart rate of around like 20 to 30. That's not fast enough to maintain life usually. So if that's what your patient's dealing with, they're going to be showing all kinds of signs of death. Basically, they're going to be pale, ashy skin. They're going to be at that, sign of impending doom where they look at you and go, "Please don't let me die," that kind of thing. So if that's the level that their heart's at, a lot of times they're going to look scared. They're going to look like they're sick as hell, probably about to fall out on you because they are about to fall out on you. All right, so enough of the heart, otherwise we'll be here all night. Your arteries and your veins, these are going to be what carries the blood around your heart, or around your body rather, I'm sorry. So arteries carry the blood away from the heart, whether it be oxygenated or deoxygenated. That doesn't differentiate because of your pulmonary arteries. Starts with your aorta. Your aorta comes across, if you've ever, you look at the picture of the heart, you see that little half circle hump at the top. That's your aorta, but it's not just that. The aorta goes all the way down the center of your body to a little bit below your belly button, and then it branches off and becomes your femoral arteries. All the way down, that's a massive, massive pipeline for blood. It's a thick, hard to break vessel. It kind of sits close to your spine. It's not something that you're going to feel up around your belly button. There are some problems that can come up with that. We'll sometimes get patients that have aneurysms, for example, which we'll talk about more when we get into the cardiac emergencies chapter. But for the most part, this is a very well protected. It sits really, really deep inside of us, protected posteriorly by the spinal cord, but on the anterior side, all of your other, you have to get through all your intestines to hit your aorta if you were to take a hit from the front. But your aorta branches into all your main arteries. So you have your coronary arteries that feed the heart, your carotid arteries that run up each side of your neck and feed the brain, your hepatic arteries, your renal arteries, and your mesentery arteries. So if you remember from your medical terminology chapter on Thursday, hepatic, anything HEPA, is what? What organ does that refer to?
The Bessian valve.
It may be. I don't know. I don't think I've ever even heard the name of it.
The coronary sinus valve.
Yeah, that's probably it.
Wouldn't it be your liver? Your liver?
There you go. All right. I was waiting. Yeah, anything HEPA has to do with the liver. So hepatitis, all right, the disease, that's a swelling or an inflammation of the liver. The hepatic arteries, those are the arteries that feed the liver. It's got its own blood supply. It needs it because your liver is your filter for the body, right? Everything you eat, as it breaks down, it goes through what's called the portal circulation, which is the liver's own circulatory system that it uses to filter out what you're using, pull what it can for energy, and then get the rest of it ready to be expelled out if you either through your kidneys or intestines to go to the bathroom later or whatever. Your renal arteries, those are for your kidneys, and then your mesenteric arteries, which is pretty much your digestive system. Okay, so your pulmonary artery, let me check the time. I want to make sure I don't keep y'all here all night. Your pulmonary artery originates at the right ventricle. This is what gets the blood to and from the lungs. This is the backwards artery. This is the one that carries the oxygenated blood. And your pulmonary vein is the backwards vein. It carries oxygenated blood. Your arteries, as they go out to the body, they're going to branch into smaller arteries, just like how your bronchus did to your bronchioles in your lungs. So you're going to go arteries to arterioles, all right, and then from there you're going to go down to the capillary beds. In your capillary beds, that's what actually has the gas exchange at the cellular level. So the oxygenated blood going through the cap beds are going to give oxygen to the cells, and at the same time they're going to pick up the waste from the cells, which is carbon dioxide, and work their way back through your veins all the way to your heart before getting pumped out to your lungs for you to eventually breathe it out. All right, so here's a better view of your vessels. Now notice when we check a pulse, what are we feeling? Are we feeling an artery or a vein?
An artery.
An
Going to
artery.
be an artery.
Absolutely. So because by the time the blood gets down to the capillary bed, it really can't have pressure to push, the heart. You don't really feel the heartbeat at that point anymore. So your veins definitely don't have a pulse to them, right? There's no pulsating or anything in the vein. You're feeling the artery side. So if I'm checking the radial pulse, I'm actually feeling the radial artery. The carotid pulse is the carotid artery. Popliteal pulse is the popliteal artery, that sort of thing. That also affects when we start talking about trauma. That's going to affect how the blood comes out of the body. If it's an arterial bleed, every time the heart beats, it's going to spurt. If it's a venous bleed, there's no pressure behind it, not like a pulse pressure. So it'll be a steady flow. And then depending on how big that vein is, just because it's steady doesn't mean it won't be severe, right? So just keep that in mind. That's going to be some things you want to have locked away in your brain so that you can think about, like if you're dealing with bleeding control, for example, if it's shooting across the room like Spider-Man webs or whatever, that's going to be a major problem. That's an artery. And if they're losing all their blood from that artery, that means everything that artery feeds is not getting blood. Depending on what artery it is, that could be a major problem. If it's a carotid artery, if somebody's severed the artery in their neck, that means that the brain's not getting the blood it's supposed to get. So you have two problems. You have the blood loss, and you have the fact that their brain's going to get hypoxic and they might have a stroke. So that's where that's the kind of the takeaway thing from this chapter. It's not so much that you just learn anatomy. I want you to see how it's going to affect the body when things go wrong. All right, we already talked about capillaries. Veins are basically your arteries in reverse. So in the direction that blood moves, you're going to start with the small ones, the venules, and you're going to get bigger. Then you're going to get the veins, then the two vena cavas, then you're back to the heart. The main thing I want you to know about, and the reason why I bring up the size of the arteries and the veins, is what if you have a clot? If you have a patient with deep vein thrombosis, which means that the veins in their legs have a problem with creating clots. If a clot forms in a vein, and you know the direction that the blood travels in the vein and where it's going, where do you think the clot's going to get stuck? Will it get stuck possibly in the head or in the lungs?
The brain?
If it's in a vein, where's it ultimately going to go back to?
The lungs.
The lungs and the heart.
Right. It's ultimately because the veins are going to get bigger as it goes. So it's not going to get stuck. If a clot forms in a vein and then starts moving, it's not going to get stuck between, because the vein's getting bigger. So it's only going to have more room to move, but eventually it's going to reach the heart. Then it's going to go off to the lungs, where now it's in an artery, the pulmonary artery, and the arteries get smaller as it goes. So you're going to get stuck in the lungs, and that's going to give your patient a really hard time breathing. That's one of the problems with people with deep vein thrombosis, is that they throw clots into their lungs and then they have a hard time breathing. Sometimes they'll go into sudden respiratory arrest and then fall dead on you, depending on where it gets stuck, or at least respiratory distress, where they're still breathing, but they can't. Again, we talked about the blood has to be moving for the oxygen to get into it. So if it seals off, that means that whole section of the lungs no longer has blood flow, which means that they don't get that oxygen from that part of the lung anymore. If a clot forms in an artery, however, that means that it's going to be going. It may get stuck somewhere in the body. That's common. It doesn't always go to the brain, but if it happens to be a clot that forms in the heart on the left side, or in say like the carotid artery, or the depending on what part of the aorta it's in, that sort of thing, there's a chance that that clot could go to the brain, and then you wind up with a stroke. So again, it's just knowing what that means. If you show up to a patient, they tell you in their patient history that they have deep vein thrombosis and they've been sitting down all day, chances are they're going to form a clot, and that clot could go to their lungs. So if you have a patient with trouble breathing, you can kind of connect the dots that way. Your spleen is a solid organ. It's located under the rib cage in the left upper part of the abdomen. So I know a lot of pictures show the liver going all the way across the body. It's like you got this giant portion of it in the right upper quadrant, and it gets smaller as it goes to the left side. It's really not that long. It actually stops a little bit closer to midline than what some pictures show it. Your spleen, it looks like a flat stomach. Like if you picture that curvature of your stomach, the spleen kind of resembles that, but it's on the right. I'm sorry, it's on the left upper side. It's opposite of the main portion of your liver. Your spleen is extremely, extremely vascular because of what it does. It filters your blood. So it's got to be able to take a whole lot of blood at any given time. So and you don't have a bunch of big arteries in it, but you have you just have a bunch of arteries. So if your patient takes a hit and they rupture their spleen, the amount of bleeding that's going to come from that is massive, and it can be life-threatening. Not to mention, if it's prior to the spleen's filters, it may be toxic blood, and that's going to be dumping into their body and all that. So you got all kinds of other problems, which we'll talk about down the road. I just want to point the spleen out because of the amount of blood vessels that go through it. If anything happens to it, your patient could have a life-threatening bleed, and that's a hard thing to deal with because we can't stop that bleeding. Internal bleeding we really can't do anything about. So we do our best to try to stop it from getting worse. Sometimes if you can get your hands on a junctional tourniquet, if the ambulance company you go to work for, you can use those for certain internal bleeds that are in your trunk. But because the spleen sits up so high, it's almost protected by the ribs. It's just underneath your diaphragm. It can be really hard to get a junctional. Even a junctional is going to be hard to work with on that because you have to get it placed just right and hope that the rib isn't stopping you from getting good pressure. For your blood composition, you have your red blood cells, white blood cells, you have your platelets, and your plasma. Your plasma is just water for the most part. That's what gives your blood that liquid consistency, because your red blood cells, your white blood cells, and your platelets are all solid. So if you didn't have the plasma, you would just have powder basically in your vessels. Your red blood cells are what carry your nutrients around, and they carry your waste back. Your white blood cells are what fight your infections, and you have your platelets for clotting. Some interesting things about this: your body typically only keeps a certain amount of white blood cells. So if anybody in here ever works in a lab or a hospital or whatever, you've ever noticed how they draw your blood and they give you a white blood cell count. If the count is elevated, it tells them that you have an infection somewhere your body's trying to fight off. Your platelets, you also typically have a certain range for those. Not leukemia, I'm sorry. Certain patients will have not enough platelets, and so they're considered free bleeders. They'll bleed and they'll continue to bleed and continue to bleed, and it's because they can't really clot off. They don't have enough platelets to do it. Blood pressure is the most important vital sign according to your body. Your body's going to try to do everything it can to maintain your blood pressure, and it will do so at the expense of your own ability to breathe. It's weird. We know that our airway is pretty important, right? We got to be able to breathe. But physiologically, your body, most of your vital signs serve to maintain a good blood pressure. So your pulse, a lot of times will either it's your pulse is actually one of two things that is most commonly changed by your body on its own to maintain the blood pressure. So if you have a patient that's lost a lot of blood, less blood in the system means the pressure is going to drop. So the body's compensation method is to raise the pulse. If your white blood cell count is low, that's typically if it's all right. So if it's low because of a condition that's called leukemia, um, that usually means that you have some kind of immunodeficiency. That itself might be the immunodeficiency, but you're going to be more susceptible to getting sick. It's not normal for your white blood cell count to be low. Your body wants to keep a certain amount at all times, like a standing army. Yeah, there you go. So for you to, let me, unmute for a minute. Do you work in a lab, or what do you, are you a phlebotomist? Okay, cool. So if I say something and I move on and you want to add to it, I tell you what, feel free to inject some things just to help out the class a little bit. Your blood pressure has two numbers. You have your top number and your bottom number. Your systolic number is your top number. That's what you get. That's the pressure in your vein or in your arteries every time your heart beats. So that being said, why do we call it asystole? If a patient flatlines and there's no heartbeat, think back to your medical terminology chapter. If something starts with an A, what does that mean? It's not really before, it's without. So if you are asystolic, that means you don't have systole, which means you don't have a heartbeat. So a flat line where like you see it on TV, they look at the monitor and it's just a flat line. And they're like, "Oh my God, we lost him." That's asystole. It means you don't have a heartbeat. That's why we call it the systolic blood pressure. Those words all go together. Your diastole, this is what's in your system at all times. So when you remove the pressure increase from the heartbeat itself and you look at what's in the system between beats, that's your diastole. That amount of blood there, that amount of pressure is usually dictated by either how much fluid's in the system in general or how constricted or dilated your blood vessels actually are. Usually those numbers have a set range difference. So like a normal blood pressure textbook has always been 120/80. And I know they're talking about raising that because so many people have hypertension that 120/80 is actually a really good blood pressure by today's standards. You really don't. Okay, did they raise it? What is it now? I know they were talking about doing it the last time I looked at it. I think they still consider 130 to be hypertension. So they didn't really raise it that much, but it has climbed. If you've got 120/80, you're in really good shape by today's standards. But your blood pressure, and we'll do a vital signs class at your boot camp. I will be at your boot camps, even though I'm not going to be your primary instructor. And I can teach you guys a vital signs class on this. But depending on how the numbers move up or down, or they spread apart, get close together, all these mean different things. I'll go over that stuff, and it's really cool because you'll be taking vital signs, and if you're worried about whether your patient's going into shock or if they have a traumatic brain injury, something like that, just looking at their blood pressure can give you a lot of tool or a lot of information on where they are in that progression. All right, so like I said, your top number is systolic, your bottom number is diastolic. Makes sense. That's why it's an improper fraction, right? The big number is on top because that's where the extra pressure from the heartbeat is. Normally, your circulation in adults is automatically adjusted and controlled. We really don't have to think about it. Our body just makes a decision on the fly, and it does it constantly. It's a constant balancing act, and it just goes on as long as everything's working like it should. The term perfusion, this refers to the ability of cells to get and give oxygen and waste at cellular level. So Hypoperfusion doesn't necessarily mean the circulation of blood itself or the presence of blood or something like that. Perfusion means the ability to get that gas exchange. So hypoperfusion, which is hypo means low, that means that for whatever reason, and there's a few, for whatever reason, your cells aren't able to get the oxygen that they need from the blood, and they're not able to give that carbon dioxide back. And that could be from blood loss, right? There's just no blood. It could be that there's some kind of sepsis going on that's in between the cell and the capillary bed, so that there's some kind of fluid that's stopping that exchange. It could be cardiogenic, where it's not that there's no blood in the system, it's that the heart's just not beating. It could be obstructive, where something has blocked the flow. There's, like I said, there's a bunch, and we're going to talk about that more and more as we go through the course. But just know that. So we call that shock in general. Hypoperfusion is shock. Shock's a blanket term. And then this just explains your capillary bed for your circulation. So you can kind of see it laid out. The capillaries are microscopic. They are meant to feed individual cells. So they're very, very small vessels. But this is why you don't feel a pulse in their veins. Because if you still had enough pressure from the heart to feel it in the veins, it would have just, by physics, it would have just blown all the capillary beds between the vein and the artery. Inadequate circulation. The system can adjust to compensate for a small amount of blood loss. If you lose a little bit of blood, it's no big deal. If you lose a lot of blood over a long period of time, it's no big deal. Your body can adjust. If you lose a lot of blood too fast, that becomes a problem. And so your body's ability to compensate is done in a couple of ways. So the heart can beat faster, right? We can raise our pulse, which, just to kind of point this out, all ages can do that. From a baby to a 99, 120-year-old, however, whatever the oldest living person is, their heart's able to pick up the pace if it needs to. And your vessels can constrict. Now, the problem there is that's not something you're born with. Kids don't really have that ability to constrict their blood vessels. So when they're compensating for shock, all they have is the ability to raise their heart rate, which they do very well. And that's kind of the problem, though. You'll get a child that's probably going into shock, and you'll see an elevated heart rate, and you won't think anything of it. And you'll be halfway through your call, and you still have an elevated heart rate. And you don't think anything of it because their hearts beat faster anyway. And then all of a sudden they crash on you, and you're like, "Holy crap! Where did that come from?" And it's because children, they compensate very well, but when they decompensate, when their compensation fails, there's no plan B. They just crash. Like, that's it. There's no, well, we have this backup, but it's just not as good. And then when that one fails, we have this backup, but it's just not as good. Adults, we do have the ability to constrict our blood vessels, which prolongs that crash. So we tend to just kind of, we call it circling the drain. You see somebody getting progressively worse, but they didn't just fall off a cliff, right? Kids are a lot more scary. With either a very large loss, but mostly a large loss in a short amount of time, the patient can go into shock. It has to happen faster than what the body can compensate for. Or it has to go for so long that the body just can't compensate anymore, because your heart's a muscle. Just like anything else, you can't grab a weight and pick that weight up for days and days without putting it down. Your muscles are going to tire out. Eventually, your heart's going to tire out too if it's beating too fast for too long. Your MAP, which is your mean arterial pressure, that's actually a really important number for paramedics. If you can get that, if you can remember how to do it, then fantastic. Your paramedic will love you. But you don't have to know it for this class. I'm going to tell it to you. If you can remember it, fantastic. If you can't, no biggie. You can learn it down the road. But your mean arterial pressure is your heart rate times your stroke volume, right? So you're getting your cardiac output times your systemic vascular resistance, which is your blood pressure. So that's how you get MAP. You just basically take those three numbers and you put it all together. A lot of times the monitor will do it for you. If you've ever been in a hospital, one of the numbers up on the screen is your mean arterial pressure. It does all the math for you. In trauma, they've really started harping on MAP getting that map and maintaining it over a certain point, it's actually become more effective than trying to treat in blood pressure, which is what we've always done. The only thing is sometimes, like I said, it's harder to get that map, it's harder to get that number. So it's just easier, it's much easier to get a blood pressure. So a lot of times paramedics they'll just deal with that. But a lot of your follow-on training is starting to really drive you down that road. So now they're even putting it into EMT curriculums. All right, so nervous system control of the cardiovascular system. We're about to get into the nervous system itself, but I'm going to save that for the next break. But I want to talk about how it affects the actual cardiovascular system, and then we're going to take a break. You have two main, I don't want to say this. You have two main halves of your neurologic system, and I don't mean that physically. I just mean that in like roles and responsibilities. You have your sympathetic nervous system and your parasympathetic nervous system, and there are two functions. Your sympathetic is your fight or flight response. All right. So imagine you've got the caveman and he's just sitting there by the campfire and he's eating his dinner or whatever, and a saber-toothed tiger attacks. The holy crap, I'm being attacked. I got to get on the defense, and you either fight or you flee, right? That adrenaline spike, that's your sympathetic nervous system. And with that knowledge, think about some of the things that that's going to do to you physiologically. It's going to raise your blood pressure and your pulse rate, right? Anybody ever been scared? Like something startles you and you kind of jump a little bit, your heart starts racing. That's a sympathetic nervous system response. All right. Your pupils will dilate. Now, what that means is that they're going to get bigger. And the reason being is because, again, if you think about it from a threat standpoint, if you're in the dark and something is stalking you, you want to be able to see better, right? So you can see the threat coming. So your pupils will dilate. They'll get bigger. They let more light in. You can see in lower light. That's the reason for that. So all of that's part of the same response, part of that fight or flight. And this is where I kind of, when I hit on it in the muscles, I said, body functions can only operate in one way. The sympathetic nervous system cannot calm you down. All it can do is amp you up, and it's constantly trying to pull you in that direction. The counterpart to it is your parasympathetic nervous system. That is what calms you down. So when your parasympathetic takes over, your pupils constrict, your blood pressure and your pulse drop, and you can relax, go to sleep, eat, that kind of thing. Those two systems are in a constant tug of war. The sympathetic can be human superpowers. The parasympathetic is more like the dude from The Big Lebowski. They're in a constant tug of war with each other. So, sympathetic's trying to run away. Like, all right, come on, let's go. And parasympathetic is sitting there like, no, hold up, and which one wins out? There's a meme, I saw it on Facebook a while back. It's like, this Indian sage or whatever said, there's two wolves in your brain basically, or in your life, and the wolf that you have a good one and a bad one. Which one wins is the one that you feed. Well, it's the same thing with this. If your body needs that sympathetic response, your adrenal glands kick some adrenaline into your system and it spikes it. So now suddenly your sympathetic nervous system is much stronger. It starts to win that tug of war fight. So you get that response. When you're done with it and your body's ready to calm down, your body sends out some hormones that kick the parasympathetic into overdrive. So now the parasympathetic starts to win that tug of war fight and pulls your vitals back down. If you, I'll say this before I move off the slide, but if you have a spinal cord injury above C3, I think either C1, C2, C3 is a high cervical break. Not so high that you lose function with your heart and lungs, but that's why I'm pretty sure it's C3. If you have a break there, you actually disconnect your parasympathetic. And so your sympathetic is now running unopposed. There's nobody holding the other end of the rope, so it just takes off. And so you're going to see patients with a sky-high pulse, just raging. Pupils are going to be, you almost can't see the color in their eyes anymore because the pupils are so big, that kind of thing. That's something you might see in a car wreck. So if you come up on a patient and you check their vitals and everything is maxed, you can't get a blood pressure because cuff doesn't go that high, for example. There's a very real possibility that they have a spinal cord injury at that point and has caused their parasympathetic to be disconnected. All right, it's 9 o'clock. Take a break. Not a full 10 minutes because I don't want to keep you all too late. So be back 10 after, and we'll continue and pretty much finish out the chapter from here. All right, we're going to pick back up where we left off. Let's go ahead and finish up. We're going to hit nervous system and maybe one or two more and we'll be done. So we've got about 30 slides left, 30 and some change. I think maybe 34 total. And so we're not too far, but we're going to get back on it now and finish up strong. So, all right, the nervous system. The nervous system is perhaps the most complex organ system in the body. If you want to be a really rich doctor, go be a neurologist. They're divided into two main portions. You have your central nervous system and your peripheral nervous system. Your central nervous system is just your brain and your spinal cord. That's it. Very easy. It is completely encased between the skull and the spinal cord. I'm sorry, spinal column. And I say that's it. It's just those two things. I mean, there's a lot within them, but I'm not going to go that deep into anatomy with y'all. If you want to learn it, by all means. They do get real in depth in like a college anatomy course, but for the points of the EMT, we really don't have to go that far into it. So for your brain, you have some major subdivisions of the brain. First off, you have your cerebrum. This is the bulk of your brain. It's divided into two hemispheres. You have your left and your right. Yeah, your CNS is your main control center. Your cerebrum is the main portion of your brain. That's where a lot of your memories are stored, for example. It's not so much that it does anything with your body systems. That's going to be down in your brainstem area, but that's where your higher thought is, your cognitive abilities, your memories, that kind of thing. And I want to point out that in the cerebrum, on the left hemisphere, kind of toward the anterior side of the brain, so kind of close toward mainly your left temple area, is an area called the Broca's region. And you don't have to remember that particular name, but just know that that's where our ability to process information as far as communication goes and deliver that back, that's where that's at. So if you have a patient that has a stroke in that area, you're going to have some symptoms where they may not understand what you're saying. It's like they forgot how to speak English, or they're trying to talk to you, but the wrong words are coming out. Like they pointed a glass of water and they keep saying bathroom or orange or wood or something that doesn't fit. It's like, no, that's a glass of water. And sometimes you'll get a patient that's got that, and you can tell because they're getting frustrated, like they're trying to communicate something. They either may or may not realize they're saying the wrong word. Sometimes they do, like they hear it come out of their mouth and like, why did I say bathroom? And then they try to say water again, but bathroom comes out, and they can hear that, and so they're like, I don't get it. They'll get very, very frustrated. You'll watch them work themselves up because of that. Not always. Sometimes the receptor side is affected as well, and then they don't, they're hearing the right word, but it's not the right word. Anyway, your cerebellum, that coordinates your body movements. That's in the back of your head. It's kind of like the bottom of your skull, right above where the neck connects. Your inner ear is a major part of your ability to balance yourself. It works very closely with the cerebellum. If you have a brain injury back there, you're going to lose coordination. Like if you close your eyes and like reach your hand out to the side, straighten out your arm, and now without moving your arm, just bend at the elbow and touch your own nose with your eyes closed. If you can do that, your cerebellum is working great. If you try to do that and you stab yourself in the side of the forehead, or you completely miss your face altogether or whatever, there's probably something going wrong with your cerebellum. That's a potential sign that you either have a traumatic brain bleed or a stroke or something of that sort that's happening there. And then you have your brain stem. There's a couple of different areas within it, but your brain stem controls all of your actual vital functions. So your ability to maintain body heat is controlled there. Your cardiac and respiratory functions are controlled there, and your consciousness itself. We have a section called the Reticular Activating System, or RAS. You may see that sometimes. That is your consciousness, at least as far as like your ability to be awake. If something happens and it affects your RAS, it's like turning off the light. You're done. You're out. You're not dead, but you're in a vegetative state. That would be your comas, that kind of thing. Anyway, your your brainstem is broken into three parts. You have your midbrain, your pons, and your medulla oblongata. Let's see if that's on another slide. Nope, of course it wouldn't be. Why did that make any sense? Your midbrain is actually kind of hidden. It's up high on the brainstem, and the two hemispheres of your cerebrum kind of cover it. So if you wanted to lay eyes on it, you would actually have to take the brain in your hand, flip it upside down, and pull the hemispheres apart a little bit. It's kind of hidden. Your pons and your medulla, that's the middle bulb. The pons is the middle bulb of your brainstem, and then the medulla is actually at the very base. So that is what connects to your spinal cord. This is the medulla oblongata. And anybody ever seen Waterboy? I can't say that without thinking of something wrong with your medulla oblongata, Colonel Sanders. The spinal cord is an extension of the brainstem. It runs almost all the way down your spinal column. It doesn't go all the way to the end. All right, as you can see in the picture, once you get a little ways into your lumbar, the cord actually comes to a stop, and then you have what looks like a horse's tail. And in fact, it's actually named like it's equina spinae or spineo equina, something like that. It means horse's tail. That's all the remaining nerves that are eventually going to run down your lower body. So your spinal cord doesn't go all the way to your butt, basically, is what I'm getting at. It kind of stops around L3, I think L2, L3, somewhere around in there. And then it becomes just a bunch of nerves after that. And the other thing I want you to know is that within your skull and within your spinal column, I always get those backwards, you have cerebrospinal fluid. All right, and that does a couple of things. First of all, that holds a lot of nutrients that feed those neural cells. Secondly, it provides a bit of a cushion, and it also maintains a set pressure. There is supposed to be a certain amount of pressure in your cranium and your skull, and also in your spinal column. If something happens and say you lose a little bit of spinal fluid, or if you start to swell, so you have a bleed, your compensation mechanism may be that you'll start to kind of dip down on some CSF. But that's a slow process. And a lot of times that swelling happens a lot faster than what the brain can compensate for. And then you start to get problems. And again, we're going to have a whole nice chapter on that when we get to it. But that comes way later. That's like chapter 30, somewhere around in there. All right. So your peripheral nervous system is divided into two. You have your somatic and your autonomic. Your autonomic nervous system is automatic. In other words, we don't really control it. So those are the nerves that control your heart, they control your lungs, smooth muscle like your intestines, all that stuff. Because you don't want to be sitting there one day and be like, you know what, I'm just going to stop my digestive process. So I'm just going to will it to not do anything. Or on the flip side of that, you don't want to be trying to go to bed while going, beat heart, beat heart, beat heart, that kind of thing. You'll never go to sleep. And if you did, you'd probably die. So all that's automatic. Your somatic nervous system is what you can control. That's your ability to move your hands, twiddle, spirit fingers, that kind of thing. That's what you get to control. And that's what allows you to do things, walk, talk, harass your older brother, whatever you want to do. Your sympathetic and parasympathetic nervous system, which we talked about before, that exists within the autonomic nervous system because, again, it needs to be an automatic response. Two types of nerves within the peripheral nervous system. You have sensory nerves, which they route information from like your skin, your fingertips, that sort of thing. They route that to your brain. All right, and then you have your motor nerves, which are the other direction. Your brain says, like, for example, all right, I'm going to take my hand and I am going to willfully place my hand on a really hot stove. All right. And my skin tells my brain, hey, we decided to put our hand on a stove, and guess what? It's hot. So that's your sensory nerves. Your motor nerves say, hey, idiot, move your hand. So you move your hand. Normally that's really fast. All right. You touch something hot, you're pretty quick to pull away. Like that's pretty fast response. People with neurodegenerative diseases don't necessarily have that. Elderly sometimes don't have that. So if they touch something hot, the delay is a little bit longer. That's why you'll find it's like burn patients, if it's a burn from like a contact burn where they touch something hot. A lot of times the burn is worse in people with those those degenerative diseases, elderly patients, that kind of thing, because it took them longer to move their hand away. You just have to understand that sometimes it's not that they were like, I'm just gonna see how long I can keep my hand here. It's not what they're doing. It just took longer for them to realize maybe we should move our hand. The integumentary system, this is the largest single organ of the body. It's your skin. All right. So if anybody ever wants to quiz you about what the biggest organ in the body is, it's not the liver, it's not it's not your lungs, it's your skin. So you have two layers. And we used to talk about three, right? You had your epidermis, your dermis, and your subcutaneous layer. We still acknowledge the subcutaneous, but because it's so drastically different, they've kind of removed it and separated it from being a layer of skin. So you have your epidermis and your dermis. That's your superficial and your deep layer. Your epidermis does not have a blood supply. It's basically just dead cells, or well, soon to be dead cells. They don't have a blood supply, so they die quickly, and then they're replaced by more superficial, or the deeper cells from the dermis are coming up to replace them, and then they die and flake off, and then more are coming up and they die and flake off. A lot of the dust in a room is actually skin, especially if it's a room that does have people coming into it. You'll notice that if you have a room that nobody's been in a while, it'll get dusty, but it's not that bad. If you have a room that nobody cleans, but there's people that's regularly in there, it gets dusty a lot faster. Well, if this doesn't make your stomach turn, it's not. Yeah, it's mostly dead skin. We shed it like crazy, and we don't realize it because it's so small. We don't see the individual cells, but it's just flaking off all the time. Anyway, your skin serves a couple of purposes. One, it protects you from disease, right? This is a barrier. We have all kinds of things like Staphylococcus lives on our skin. It's naturally occurring. It's on all of us. The only time we ever wind up with a staph infection is if it somehow manages to find its way past our skin, be it from a cut, something of that sort. It allows us to maintain body heat, right? So like if you think about the hair that's on your arm, when you get cold, it stands up. That's all part of your integumentary system that's designed for you to try to stay warm. Your dermis, now we're getting kind of down into where all these things connect. So your hair cells, the follicles connect in the dermis, not the epidermis. Your sweat glands are down in that layer, all that stuff. And then your nerve endings are there as well. So if you touch if you just touch your arm, that doesn't really hurt, right? That top layer of skin doesn't have any nerve endings. It's just, you can feel the pressure. But if you take your nail and scrape across it, not hard, but just a little bit, it doesn't hurt. But God help you if you get a rug burn or something like that. It just hurts to exist, right? Air will make it hurt. That's where it's because that dermis has been exposed. That's where all your nerve endings are. And then you have your subcutaneous layer underneath it. That's all mostly fat, and that operates more as like a glue, I guess is the best way to put it. It sticks to your muscle. As we get older, that glue starts to wear off. That's why we get wrinkles and things of that sort. All right, there you go. Skin is the largest single organ in the body. There's your three major functions: protection, body temperature, and it transmits information from the environment to the brain, like, hey man, it's kind of cold out here. Maybe we should go get a jacket. The digestive system, this is what processes food and gives nourishment to your cells of the body. It starts at the mouth and it ends at the butt. Something about the nervous system that I want y'all to know is that the nervous system is the least dependent on blood. So it can go the longest without a blood supply. It's the first thing to lose blood when your fight or flight kicks in. That's why your stomach kind of turns. You don't get hungry. If you stay stressed all the time, you ever notice how you're never really hungry? Um, it's because your body is staying in that sympathetic response, that fight or flight. You don't get out of it. You really don't give a lot of blood supply to your stomach. It winds up being you just like, I'm not hungry. And then you start missing meals, which can stress you out more, so on and so on. Uh, the abdomen, when you're checking this, is when you're really going to see these quadrants come into play. When you're doing an assessment of your body, of your patient, you have 4 quadrants. They're divided by the belly button. So you have 2 upper quadrants above the belly button, 2 lower quadrants below, 2 quadrants to the left of the belly button, and 2 quadrants to the right. There's some texts, like if you've ever taken an actual anatomy class in college, they show you a 9 section. It looks like a tic-tac-toe board over your stomach, but we don't get that in depth. 4 quadrants is all you really need to know. Left upper, left lower, right lower. There you go. So here's your organ layout in your abdomen. There's a couple of things that I really want to know. First of all, the gallbladder, don't worry about it. We really don't talk about it too much in EMS. Just know that that is on your right upper. So is your liver. You know, and here you can see it. The liver doesn't really go all the way across the body like it does. It does extend to the left upper, but it's the vast majority of it is in the right. You can see your spleen kind of hanging out over there on the other side of your stomach. So if you get hit on your side, like on the side of your ribs, underneath your arm, on your above your belly button, you have a really high risk of rupturing your spleen. And then again, like I said, that comes with a lot of blood loss. As far as your lower quadrants go, your right lower quadrant has your appendix, and it's really low, and it is excruciating. And if anybody's ever had appendicitis or anything of that sort, I don't have to tell you how bad it hurt. You know, like it's curled in the fetal position on the kitchen floor kind of hurt. One of the classic ways that we always learned as EMT students, at least back when I went through, to check for appendicitis was to press on it. All right, like you press on the right lower if you think it might be appendicitis, and it supposedly will make their pain go away, or at least get less. But when you remove your hand, the pain comes back with a vengeance. They call that rebound tenderness. It's not a real good way to check for appendicitis. That's a good way to really make your patient mad at you. So something that I've learned and that we try to teach now is if you think your patient might be having appendicitis because they have extreme lower right quadrant pain, tap the bottom of their foot. If they feel that, not necessarily like if that resonates in that area of their abdomen, pretty safe to say it's appendicitis, and you can just go ahead and operate with that in mind for the rest of your assessment. If it's something like an ectopic pregnancy, that it'll hurt. That's a highly painful thing as well. But tapping their foot's not going to make a difference. The appendix sits so low and it's so sensitive when it's swollen that just tapping the bottom of their right foot it's gonna give them a different, like they're gonna feel that up there. All right, so your digestive tract starts at the mouth, consists of the lips, cheeks, gums, teeth, and tongue. Your teeth can become problems if they get knocked loose and you're worried about an airway. Some medications that we give, you may want to give it either under the tongue or in the cheeks. It's called the buccal area. If you've ever heard about something being given buccally, they're referring to the cheeks. Your salivary glands are there. That's what starts the digestive process and breaking down your food. You have your oropharynx, which is the lower half of your pharynx where your mouth is at. Your nasopharynx doesn't really count because that's above, and we don't snort our food, at least not without money involved or free beers or something. You have your esophagus. It's about 10 inches long. It's a little bit longer than most people think. It really just extends long enough to get past your diaphragm because your stomach sits below the diaphragm. And if you're like me, and some meals you just have no self-control, you'll eat so much that your stomach is so full, it's hard to breathe. Reason being is because when you take that breath, remember your diaphragm is supposed to drop. I never said that. All right. I just remember in high school it was pixie sticks. But anyway, um, I gotta be somewhat professional, okay? We can talk about that stuff later. Anyway, um, you get so full, your diaphragm can't drop because your stomach is too bloated. So it makes it hard for you to makes it really hard for you to eat, or at least I'm sorry, breathe after you've eaten, two large Papa John's pizzas before you realize you got that much food. You have your stomach and your pancreas. Your pancreas helps to um, I'm sorry, I lost my place. Um, as your food breaks down into glucose, your pancreas releases your insulin so that you can actually get that glucose into your cells. And that's what feeds your cells, the glucose portion. Your pancreas is broken into some different parts. I'm not too worried about y'all knowing that. You have the islets of Langerhans, but we won't go into all that stuff. It's just know that your pancreas is involved in digestion in two ways. One is it produces the insulin. The other one is that it creates some digestive juices that will help break down fat, starches, and proteins. You have your liver. Your liver mostly acts as a filter. Your bile ducts help get get the bile out into the digestive tract, so it helps break it down. You have your small and large intestines, and at this point, you're just absorbing everything. You're absorbing water out of your food. You're absorbing different nutrients and not chemicals, but nutrients and vitamins, that sort of thing, out of your food. And as it goes on down, it gets closer to your rectum, and then you go to the bathroom. Digestion itself is a really complicated process. So you start talking about things like metabolism. I remember seeing a couple years ago where somebody had drawn out a flow chart of metabolism, and it was massive. It looked like one of those like college professors chalkboards you see on TV where they got these massive equations written all over the place and everything, and you're like, I don't even know where to start. That's what metabolism looks like when you draw it out. Way beyond anything we're ever going to go into in this, or even anything remotely close to this level of training. But it all breaks down basically. You start eating, starting with your saliva, your stomach, your liver, all that stuff dumps more and more enzymes into the food that you ate. With that, it starts to break it down on a molecular level so that your body can digest it. Your food gets broken down into sugars, fatty acids, and amino acids. The amino acids help with your protein building. Fatty acids are good for you, and sugars, as long as they're good sugars and sugars you get from food, it's not bad. It's not the same as like processed sugar. These basic products of digestion are carried across the wall of the intestine to the liver, where they enter what's called the portal, like portal. I don't know. You can think sci-fi, I guess. Portal, Portal, portal circulation, and it basically just pulls the nutrients out and sends it around to the body. That's something we have to keep in mind when we start talking about pharmacology. Um, Medications that are taken by mouth have to go through portal circulation. The liver starts trying to get rid of that stuff and get it out of the body. That's just what its job is. So if we want to give you a medication that we want to go say like we want to get it around the portal circulation where the liver doesn't affect it, we have to give it to you in a different way, an IV, inhale it, um, anything other than by mouth. Okay, because that's if you swallow it, it's going to go through the liver. So your lymphatic system, you have your spleen, lymph nodes, the lymph itself, your lymph vessels, the thymus gland, and other components. This supports circulatory system and immune system. It basically is a filter. You have lymph nodes all over the place, and like the two easiest ones to feel are kind of underneath your jaw, a little bit in front of where the curvature of the jaw is on the sides. The thing about lymph, it mostly cleans your blood. So when red blood cells die, because I mean they're cells like anything else, right? They're gonna eventually reach the end of their lifespan. More blood cells are gonna have to be made. It's your lymphatic system that cleanses all that, right? So it's not really cleansing things like food toxins that we would get rid of, right? Our liver does that, but the blood itself, your lymph takes care of that. Your endocrine system. The endocrine system is a complex message and control system. So the easiest way for me to explain this in a way that will make good sense, and I don't have to really harp too much on, like, because the lesson plan has a whole bunch of crap on the endocrine system. But think about it like this. We always talk about the neurologic system being the control center of the body, right? The brain wants to make my hand move or whatever, that's fine. My brain says move, electrical impulse gets sent, I move my hand. But to kind of put this into an easy context, what about when I want to spike my heart rate for 10 minutes and only to a certain point? Electricity is either there or it's not, right? And it's either, it's 0% or 100%. So how does that work? The heart does, I'm sorry, not the heart. The brain doesn't tell the body to spike vitals directly. What it does is it coordinates the brain tells the endocrine system what it wants. So your adrenal glands, they sit on top of your kidneys and they release excuse me. They release adrenaline into your system. So if I need to spike my sympathetic nervous system, I'm not zapping my heart with electrical impulses from the brain. I'm zapping my adrenal glands. And the longer I apply electricity to them from the brain, the more adrenaline they dump into my system. So the brain's going to be like, all right, I'm watching the gauge and I'm going to just sit here and just continue to torture my adrenal glands with electricity until they release enough insulin to get this gauge where I want it. And then I'm going to leave it alone. And when the gauge starts to fall, I'm going to zap it again to get it back up or whatever for however long it needs to. And that way you have a gradient of how your body operates. So it's not 0 or 100 only. It's 100% to the endocrine system, to the whichever gland it needs to. And that gland basically just cries hormones out of itself until you get the right amount in your body. And then the brain's like, okay, cool, I'm happy now. And then you use whatever's there. And then if you're fine to come back down, the brain leaves that organ to do its thing and everything's good in the world. That's how the endocrine system works. Each different gland has its own purpose. So like your pancreas, for example, plays a part in maintaining your blood sugar. Your adrenal glands, they play a part in maintaining or spiking your sympathetic nervous system if it needs to. Every gland's got its own thing. So that's the point with that. We won't get really too much into anything else. Let's see. We've all heard the pituitary gland is like the control center. Fine, whatever. That's easy. It really has no meaning. We don't touch on it too much in EMT. The ovaries and the testes, spoiler alert, those are the same, right? So if you're forming as a male, you're going to have testes. If you're forming as a female, you have ovaries, but it's the same gland. It's made from the same cells. They're the same. The brain controls the release of hormones. Again, like I said, it's got all of your endocrine glands are connected with battery cables with their feet in the puddle of water. And the brain is in control of what they release and when. The tightly controlled communication system uses primary and secondary feedback loops to keep the body in balance. So if you are sick, if the body realizes that you have an illness, the positive feedback loop is going to say, all right, well, cool. You want to live in 98.6 degree temperatures? Well, I don't want you, so I'm going to crank up the heat. Positive feedback loop raises your core temperature up until to a level that it thinks is going to make that illness want to go find somewhere else to live. Once the body realizes that the fever is hurting it too, then the fever is going to break. Your negative feedback loop is what pulls your body core temperature back down to the 98.6. Hopefully by then it has killed off whatever it is that you're sick with. Usually it doesn't. That's why we keep getting fevers recurring. But that's an example, right? So a fever is not a function of a disease. A fever is your body's attempt to get rid of the disease or virus, stomach flu, whatever it is you've got. This is an example of not an example. This is just a picture to show you where your endocrine glands are. The adrenal glands sit on top of your kidneys. You have your ovaries and your testes, your pituitary glands in your brain, and your thymus. Don't so much worry about that. That is a big growth um, gland. We still technically have it doesn't just disappear, but it does kind of shrivel up and shrink as we get older. It's really big in kids. It's active in kids, but as an adult, it's just like a withered remain of what was there before, because it spins itself out as you grow. The urinary system, we're getting pretty close to the end, guys. The urinary system controls the discharge of certain waste materials filtered from the blood by the kidneys. Mostly it's going to be things like ammonia, some of your acids that raise your pH balance. That's what your kidneys clear out. You'll pee out certain nutrients, different things like potassium, any unused vitamins. So if you take a whole bunch of vitamins, multivitamins and stuff like that, or supplements that you don't use, you just pee it out, right? Your body's trying to maintain that balance in your bloodstream, and it tries to maintain that pH balance too. It doesn't work as fast on the pH as your breathing does. So your breathing, your respiratory drive is the main buffer for the pH balance, but your kidneys do control that as well. If your body decides that it's got too much potassium, you'll start to go to the bathroom more because you're trying to flush that out. If your body decides that you need something and you don't want to lose it, like salt, for example, if you got too low sodium, too little calcium, one of the first things your body does to try to stop that fall and get some built back up is it slows your kidneys, which means you don't go to the bathroom that often. So nurses especially will start to track patients' input and output. We can do that too as EMS. Sometimes you may want to ask them, when's the last time you went to the bathroom? If your patient is showing something that makes you think their pH is out of balance, or they're, maybe an electrolyte imbalance of some sort, finding out when the last time they went to the bathroom, how much they've been going to the bathroom, that all plays into it. All right, so your body has two kidneys. They actually sit in your upper quadrants. Everybody, at least everybody I knew, used to think that your kidneys were really low, like down around your hips almost, or like sitting just above it. That's because the pain defers to that area. But the kidneys actually sit above the belly button. They're pretty high up, but they're far back. They're posterior. So if they are inflamed, if they're hurting, you feel the pain kind of around to your backside. It's because the kidneys sit back in that half of the body. The two kidneys dump your urine down the ureter. You get one for each kidney. They go to your bladder. It's your waiting room. We all know what the bladder is. And then from the bladder, it moves out through your urethra, and then you pee. The prostate gland, that is a male-only organ. Women, lucky y'all, you'll never get prostate cancer. All right, so the next system, I am not going to say anything about out loud because I have some varying age ranges in the room, but I'll let y'all read this. If you have any questions, type it in the chat. Probably be the best way to do it. This is the male slide. There's your diagrams for anybody that hasn't had like a high school health class or something of that sort to know what the internal workings are like. This is your female side with the pictures. Now I want to point this out because this is important. I can easily say this in mixed company. If you look, the fallopian tubes don't connect to the ovaries directly. They basically have what looks like a little flower head that just kind of rakes the ovaries. So when an egg is released, it just kind of grabs it and pulls it into the fallopian tubes. You release one from each ovary each month. So odd months may come from one, even months will come from the other. If you have a patient who has had to have an ovary removed, it doesn't mean that they can't get pregnant. It just means that it's on an every other month. 1 month they can, 1 month they can't, 1 month they can, 1 month they can't. All right, so the life support chain, basically, let's look at this. You're looking at this from like a biology standpoint here. So cells are the foundation of the human body. The smallest living organism is a cell. And they require food just like we do. So their food is oxygen and glucose. That's what they need. If you take one away, the cell can't operate properly. It can operate a little bit, but it's not as efficient. You need oxygen, you need glucose. So your cells will constantly pull that in, and then they evict carbon dioxide and other wastes as necessary. The respiratory and circulatory systems are what carries the supplies to the cells and the waste back out away from them. And if there's any kind of interference to that, the cells can become damaged and die. I'm not going to get into the Krebs cycle. I think that's way out of range of the EMT, but some other instructors like to bring it up. I just don't want to confuse you all. You're never going to get tested on it. If you go into paramedic school, you'll want to learn the Krebs cycle, but we won't. I'm not going to say it. So your cells use oxygen to take available nutrients and turn them into chemical energy through metabolism. That's called aerobic metabolism. All right, you're using oxygen. If you remove the oxygen, your body can still create the ATP. It can still create energy, but it does a horrible job of it. It takes more energy than what it's creating. So you're on a downward spiral if you don't have oxygen. That's called anaerobic. Again, we can live. It's not like if you just hold your breath, you immediately die. We can still function for a while without oxygen. It just doesn't last long. Eventually, you're going to get sleepy. You're going to get tired. You're going to start to wear out, pass out, go unconscious. If you don't fix it, you're just going to fall asleep to death. If your cells are trying to operate without oxygen, they build up a lot more lactic acid because they're creating that ATP, but they're doing it in a bad way, and they're getting a lot of byproducts out of it. Lactic acid, we get that when we exercise. It's not bad in itself. So if you think about like when you go to the gym and you're lifting a heavy weight and you just keep lifting, your arm starts to burn. Or you just, even if you don't lift weights, if you just hold your arm up and do arm circles like your PE teacher used to bully you with when you were a kid, that burn that you feel, that's lactic acid buildup. And then like you finally get to lower your arm to the ground and it feels like it's just pouring down because it is. Every cell can do that. That's just an example. All right, your pH is critical to diffusion. Your body likes to sit between 7.35 and 7.45 for a pH. It's just a little bit on the acidic side. We try to keep it in that range. Your body does it on its own. Like I said, if it starts to get too acidic, your respiratory drive is going to pick up and you're going to start breathing off carbon dioxide very fast. And then just like that, your pH starts to lower and you get closer to 7. If you're getting too low, your breathing slows down. And your kidneys function to help this as well. But they're a little bit slower, a little bit more long-term process. Your breathing is what gets you the quick changes. All right. Pathophysiology. If you guys go to a higher level of training, you're going to have a chapter devoted to this and not just 5 slides. Pathophysiology is a study of functional changes that occur when the body reacts to a disease. And we're going to have, when we go into the medical chapter, you're going to get a pathophysiology section for everything that we talk about. Because, you want to know what the disease process is. Because if you know what's going wrong, you can kind of figure out what's going on with your patient and then know what to do. Many diseases can occur in patients. For example, diabetes is a disease with the pancreas if it's type 1. If it's type 2, it's a disease with your diet usually. But it winds up being, especially diabetes like type 1, where it's an insulin issue. The pancreas typically isn't creating it like it's supposed to, and then that's your problem. Your stroke is a disease of the brain. I suppose you could look at it like that. And then pneumonia is a disease of the lungs. Respiratory compromise is the inability of the body to move gas effectively. And this can lead to hypoxia, which is low oxygen in the blood, or I'm sorry, low oxygen in the body, or hypercarbia, which is elevated carbon dioxide. If you stop breathing, those two things will happen. You're not bringing any more oxygen, and you're not expelling any carbon dioxide. Your cells are still creating it. So the carbon dioxide is going to climb. They're burning out the oxygen that you already had, so your oxygen level is going to drop. All right, factors that impair ventilation. When we start talking about your patient assessment, you're going to finally get to your primary assessment. If you've ever heard of that before, if you've ever been in EMS or whatever, we usually always start with airway. All right, airway is just the route from your mouth and nose to your lungs. So that being said, the things that can impair that are right there at the top. Blocked airway, right? You choke on a piece of steak or bread or something like that. Impairment of the muscles of breathing. If something happens, let's say you fracture a C-spine, one of your cervical spine, and you sever your phrenic nerve, which is what powers your diaphragm. So I'm drawing a blank on words here. If you cut off the nerve that controls the diaphragm, you can't breathe anymore. Your diaphragm is not going to contract. You might still be able to get chest rise, but that's nowhere near. That by itself is not the primary driver of your ability to breathe. So you'll get like 20% of your air capacity if your diaphragm doesn't do anything. Airway is obstructed physiologically, so asthma attacks where the bronchioles start to spasm or constrict, drug overdoses, allergic reactions, you get shot or stabbed in the chest, or you get some kind of blunt force trauma to the chest, that can cause it. Pleurisy can cause it just because of the extreme pain. Like there's really not a physical barrier to you breathing, but because it hurts so bad to take a breath, you can't do it. The pain overrides your ability to take the breath. And then factors that impair respiration. Remember, this is the gas exchange. So changes in atmosphere, high altitudes, impaired movement of the gas across the cell membrane. If you have congestive heart failure, if you have a septic reaction where you've got some kind of fluid kind of just building up outside the cells. If it's outside the cell, that means it's going to be getting in the way of that capillary bed, and you don't always get that gas exchange. So those things can kind of play into it. Ventilation and perfusion mismatch, where you may be breathing or bagging your patient, but you're not, the blood's not moving. So even though they got the ventilation, the air's going in and out, it's not able to make that exchange at the alveoli. The VQ ratio just describes how much gas is being moved effectively through the lungs. It's not necessarily something you need to, it's not a math equation that I want you to know. Just understand that everything works in harmony, right? The speed that the blood is going through your pulmonary system and the speed that you breathe has to kind of sync up. That's why if you breathe faster, your pulse is going to increase, or vice versa. If your pulse increases, you're going to breathe faster. People that have a high pulse and we want to talk them down, what's something we usually tell them?
Take a deep breath in and let one out.
Yeah, just slow deep breaths, right? Like, all right, man, I know you're freaking out. I know you just ran the marathon and I think you might be, you don't want to say I think you're having a heart attack, but I want to try to slow your pulse. So can I do me a favor? Just take a slow deep breath, just in and out, something like that. Like count it. Let's take a 2-second in and a 4-second out. And what you're doing is you're forcing them to slow their breathing down. You're drawing attention to it because we can't physically say, slow my pulse. It doesn't work that way. But if we can slow our breathing down and they work together, we can slow our pulse down. And that's major, especially when you're dealing with a patient that might be having a heart attack. We don't want their heart to just run a marathon, redline itself when it doesn't have any oil in the system. It'll break faster. So that's something that we can do. All right, for shock, we talked about it earlier. Shock is hypoperfusion. It just means that for whatever reason, there's not a good gas exchange at the cellular level. There's a couple of different things that can cause shock, The effects are pretty much the same. If you see a patient in shock, you're going to see cool, clammy skin because the skin is no longer getting a blood supply. They may be nauseous and vomiting, or the pupils may be a little bit out of whack. If they're compensating, their vitals climb. If they're decompensating, which is what we don't want, that means they're getting to the point where they can't come back from it. Their vitals are going to start to crash. All right, and then for the last thing, we are at the end. Perfect timing too. Impairment of cellular metabolism results in the inability to properly use oxygen and glucose at the cellular level. So if there's not enough oxygen, your cells are going to metabolize energy at using anaerobic metabolism. This is a backup. It can result in metabolic acidosis, which we don't like. Again, we want to keep that pH range. And because it takes a mountain to make a molehill, your body's going to really start to decline pretty fast. That is not meant to be a long-term thing. That is meant to just get you through until you can restore oxygen to the cells. So if you show up to a patient and they're having a hard time breathing, that is problem numero uno, unless they're just hemorrhaging out. That's the only time that you really are going to put something ahead of trouble breathing, is if they have trouble breathing, and they chop their foot off and they're hemorrhaging out. So there's a priority scale to it, and you're going to see it when we get to your assessments, which is going to come either 1 or 2 more nights, I think. But that's going to be the name of the game for the class, is we're going to be teaching you all this stuff, but ultimately it's going to tie into your assessment, so that by the time you go to the boot camp, my goal is that you all have memorized your assessment checklist, at least the trauma and the medical. The individual skills, I'm not so concerned about. We'll do that. We'll fly through that at the boot camp. But I need y'all. I'm gonna tell you now, and I'm gonna foot stomp this at the beginning of the class. I need y'all to memorize your medical and your trauma assessments, line for line. All right, because your entire skills assessment at the end of this class to get certified is those 2 assessments. You're going to walk into a room. There's going to be a patient with a proctor sitting in the corner. They're going to read you a scenario, and you're going to go through your assessment. And you won't have the sheet. They'll have the sheet, and they're going to mark everything that you do right. You have to get X amount of points, and you have to not do any critical fails. So I would say right now, if y'all want to get a head start, if you can get your assessments, they're up on the Canvas. You can download them from the files section. If you get those, start memorizing right off the bat what your critical fails are. Know that stuff like you know your name, because that's the things you absolutely do not want to do. Because the minute you do it, they're going to stop you there, and your assessment's over with a failure. If you make a mistake in the list, that's okay. You can always go back and get it again, but you just don't want to do those critical failures. But that is it for the night. I don't usually make a habit of doing the reviews. I think Brad, I saw as he was doing them at one point, and that's fine. Y'all have access to these slides, which means you have access to the review questions. By all means, look through them. They'll only help you. But I just don't want to tie you up with review questions at night. So let me see. You sent me a couple things in Messenger, a diagram on bones of skeletal system, both anterior and posterior abdominal. Inconsistent well in my line of work. Yeah, oh, absolutely. Anything you want to share to the Facebook page, go right ahead. Like I said, it'll only help. We don't teach anatomy to the level of like a college course, just because it's not necessary at that level. Mostly the physiology. That being said, as you go through your careers, I hope that you'll want to continue learning, and eventually you're going to get to the point where you do know a whole lot more than what you learned in school. You don't want to get to the end of your career and only know what the brand new guy right out of school knows, because you never picked up a book afterward. But anyway, that's it. Your pen for the night is going to be, let me get to where I can type. Yes, if I don't have you in the Facebook page, I think there's some people I still need to bring in, like late arrivals and stuff. If you don't already have me on Facebook, look me up. My name is Robert Roy, and my profile picture is me in a dark blue Nike t-shirt holding a guitar. As soon as I have you as a friend, I can add you to the group. I just can't find you in the invite section if I don't have you as a friend. It only, for whatever reason, pulls up my friends. Okay, awesome. All right, your pin for the night is going to be BC6A. No, wait, BC. Give me a second. BC06A. Probably help if I type that to everyone. BC06A. Yep, so Bravo Charlie 06 Alpha. That will be your pin for the night. I've got this one recorded, and since it's on my computer, I don't have to wait for anybody to get it to me. It'll be uploaded to the website very quickly. Y'all have a great night. If you don't have any questions, if you do, you can hit me up here, or all y'all have my contact information. So just shoot me a message. I appreciate y'all. We're gonna have a couple different instructors teaching over time. So one night, a couple nights, you may have our med director. He likes to teach, so he'll probably come in and teach a couple classes. I've got some other flight paramedics, nurses, firefighters that are EMTs. They may come in and teach things that they find interesting as well, just to kind of help break up the monotony, give you different points of view, different experience levels and all that. But otherwise, y'all have a great night.